a bird phylogeny, you can see we've got a very prominent anterior choroidal that's sitting between the telencephalic supply of the middle and anterior cerebral and the posterior communicator PCOM posterior cerebral supply. And that choroidal supply anastomoses at the level of the tectum with the posterior circulation. So we've got an unusual artery. The anterior choroidal artery is an early artery and exists between the posterior circulation and the anterior circulation and is in balance with both of those. And to emphasize that point, if we look at this drawing of the circulation in a bird and on the other side in a human, and this comes from Pierre Legenias's book, you can see that in the bird we have the basilar artery, carotid artery, and the carotid divides into a caudal division, which is going to be the PCOM and P1. And off of that, we have a tectal artery. The carotid comes up and the cranial division is going to supply middle cerebral, anterior cerebral, but has this very large artery, which in birds is called the posterior telencephalic artery. And it's the homologue of the posterior cerebral artery. But if you contrast this with the anatomy as we draw it in humans, you can see the carotid comes up, PCOM, which is the caudal division of the carotid, runs into the P1, and here we have a posterior cerebral. And the carotid comes up, the cranial division gives off the anterior choroidal just above the PCOM. And if we compare this and put the lateral geniculate body on each one, you'll see that what in birds we call the posterior telencephalic artery is really the anterior choroidal artery in birds. The importance of this is in birds, the posterior telencephalic artery has a large cortical supply, supplying the entire visual system, whereas in humans, that cortical territory has shifted to the posterior cerebral artery. So between species, we're seeing a shift in cortical territory. What we have to remember is that this pattern of supply, because it's existed before, is certainly possible in humans, and I'll show you some examples. So to go to the ontogeny, here's the drawing from Dorcas Paget's sketches. This is the 9mm embryo, and you can see here's the dorsal aorta, the continuation, very tiny ventral aorta at this stage. The carotid comes up and divides into a posterior division that's going to be the PCOM and the upper basilar. And the cranial division comes in, is going to be the future anterior cerebral and middle cerebral artery. But at this 9mm stage, you'll notice that the anterior choroidal coming at the level of the mesencephalon and telencephalon is a very prominent artery, more prominent, say, than the little middle cerebral branches that are not yet developed at that stage. So these are the typical territories that we can then ascribe to the anterior choroidal artery. And you'll notice that this is an artery because of its location between the telencephalic supply and the posterior circulation supply is in balance with those two territories. So here's a sketch. Here's the visual pathway. So there's the optic nerve, chiasm, optic tract. And you can see the anterior choroidal is associated with this part of the supply to the visual system. So here's the anterior choroidal artery, and its cranial supply is going to be to the piriform cortex. The deep perforator supply will be to the caudate tail, the amygdala, and the globus pallidus. So those are the perforating supplies in balance with the middle cerebral artery. Then we have a caudal component. So this is going to be the part of the artery supplying the optic tract, the lateral geniculate, the crus cerebri, the subthalamus, posterior internal capsule are going to be the perforator supply. And then we've got the posterior temporal lobe supply, the hippocampus, choroid plexus, and sometimes the cortex as well. So all of these are going to be in balance, and there can be variation between these territories. So as I said before, this cortical territory distal to the choroid plexus supply is certainly possible. We're going to briefly look at the imaging, and all of you are familiar with where to find this on an MRI. It's the tiny, thin little vessel that comes off the carotid and is curving around the midbrain diving into the temporal horn to supply the choroid plexus. And if we look at that on an angiogram and focus on this lateral picture here, you can see I've chosen an example with a fetal PCOM supply. So this is a lateral view of the internal carotid, PCOM, posterior cerebral, and just above it is the anterior choroidal. This yellow point, the yellow marker, is pointing at the perforator supply, which you can just see coming off there. The red arrow is pointing at what we call the choroidal point. And this is where the artery takes this kink as it goes into the temporal horn to supply the choroid plexus. And the blue arrow is actually pointing at the choroid plexus supply. That's visible on the 3D angiograms as well. You can see the perforator supply a little bit better, and that choroidal point, and here's the typical supply of the choroid plexus. If you're interested in the anterior choroidal artery and you do a literature search, you'll see that there's some papers that suggest that it's possible for the anterior choroidal and the PCOM to switch positions. That, of course, is not true. I think it's just a confusion about the shift in cortical territories that's possible. There's no ways that the anterior choroidal can come off proximal to the caudal division of the internal carotid, which is going to be the PCOM. What is possible, though, is this arrangement where you can see on this angiogram, the patient had an aneurysm clipped many years ago, now has a small aneurysm that's appeared below that on follow-up. And if we look at the 3D angiogram, you can see the anterior choroidal and the PCOM share a common origin. So this is really just an amalgamation of the origins of the vessels, but because of the embryology, it's not possible to have a reversal of the vessels. So let's try and put that into some kind of practical application. And we'll start with a simple one, and that's stroke. So now that we do mechanical thrombectomies, we have a lot of patients that come in with stroke, and you'll notice that there's always what's possible is a cortical shift. So the example I want to show you here is a young woman who, after taking cocaine, has thrombosis of the carotid artery, and you can see the entire carotid has got thrombosis in it. But because she's young and very lucky, she has an amazing Peel collateral circulation, and this watershed shifts from our watershed area over here right down. She's got retrograde flow that sustained the whole middle cerebral supply. And if you look at the vertebral injection, she's got excellent supply of the posterior temporal branches of the posterior cerebral. So although there was some delay in treatment, and with thrombectomy, we've managed to preserve the entire cortical supply, what didn't get supply was the anterior choroidal because of the thrombosis. And she's got the typical infarct of an anterior choroidal territory. So posterior caudate, caudate head and internal capsule. And you'll know, I think every neurosurgeon knows the story of Irvin Cooper, who accidentally injured the anterior choroidal artery in a patient with Parkinson's disease while he was trying to do a section. And the patient woke up and was much better because of the midbrain supply of the anterior choroidal artery. But as you know, as I've just shown you, the perforated territory can extend to the internal capsule, and that's not going to be so good. And this operation stopped because the patients ended up with far worse deficits than just improving their Parkinson's disease. And then, of course, it's important to understand the anterior choroidal anatomy and where it comes off in terms of aneurysm surgery. And here's an old example of an angiogram, and I use it because it's just got nice intraoperative pictures. But this is an example of a patient who has two carotid aneurysms, one at the level of the PCOM and one just above that at the level of the anterior choroidal. And here's an intraoperative picture. So here's the right optic nerve, the right carotid. And you can see here's the PCOM aneurysm coming off. There's the origin of the PCOM with it curving behind the carotid to go back towards the brainstem. And at this level here, covered in Surgicel, is going to be the other choroidal aneurysm. And here's the clips. And what you'll notice is that it's relatively easy to see the PCOM origin when you're clipping a carotid aneurysm of the posterior communicator. It's very difficult to see the anterior choroidal, and that anterior choroidal is well hidden because it's more posterior and curves around the midbrain, and it's not easy to spot. Easy to injure for that reason if you include it in a clip. Here's another intraoperative example: left side, left optic nerve, left internal carotid. This is the PCOM. This is the third nerve, and here is the anterior choroidal artery. So there's no aneurysm here, and it's possible to manipulate to see it. But you can understand if there's an aneurysm there, it's difficult to manipulate the vessel and get a good view. So on this example, this is another patient here, left side, left carotid. And let me move my cursor. You can see there's a very small anterior choroidal aneurysm at the level of the third nerve. There's the anterior choroidal. You can just see proximally. And putting a clip on here, it's really important to preserve that anterior choroidal, which just means accurately placing the clip. What you've got to know is that it's a little difficult to manipulate this after you've placed the clip. So once the clip is on, you don't want to tear that aneurysm and you don't want to tear the origin of the anterior choroidal. It's very difficult to know that you've actually preserved the anterior choroidal without doing angiography. And you can see here, I'll try and manipulate the clip to have a look and make sure that the anterior choroidal is free. And it's not that easy. There we can just see the anterior choroidal origin preserved. From the embryology that I showed you and the multiple territories that the anterior choroidal can supply, you'll also know that it's possible for the anterior choroidal to have multiple origins. So it isn't necessarily coming off as a single vessel. Here's an example. Here's the carotid artery. And at the level of the anterior choroidal, we've got 3 vessels coming off. So you can have an individual supply to the piriformis cortex, and you can have an individual supply to the internal capsule. And I'll show you some angiographic examples of that as well. Another reason to really understand the anatomy of this anterior choroidal nicely is you can use that to your advantage in certain surgical approaches. So this is a transtemporal horn approach to get to the peduncle. And here's an example of a patient who's presented with a bled cavernoma, has hemiparesis, and I think Amir actually helped me with this operation. And our plan was to go through the temporal inferior gyrus into the horn of the ventricle, and then go trans-choroidal fissure to get to the peduncle. The importance of that is knowing that your landmark when you're in the temporal horn is the choroid plexus, and you have to separate the choroidal artery with the choroid plexus and reflect it superiorly in order to preserve the perforator supply that's going to be with that artery. So if we look at one of the beautiful dissections from Albert Roton, you can see this is a superior view. Here's the midbrain, here's the carotid artery, middle cerebral, A1, here's the anterior choroidal coming off posteriorly towards the midbrain, perforator going off to supply the visual tract, artery extending around. Here's the choroidal point where the vessel goes in, supplying some of the hippocampus and supplying the choroid plexus. And of course, this is the area where we're going to go in and dissect through this choroidal fissure to get to the midbrain, and we've got to reflect that choroidal tissue superiorly and preserve this entire vessel, because as you're coming anteriorly, we don't want to damage these other vessels. So this is that operation, and you can see it's quite a limited view. Here's the choroid plexus and the choroidal artery reflected superiorly. And here's the yellow staining on the peduncle extending up into the subthalamus area of that cavernoma. Not every aneurysm coming off the carotid at this level is a PCOM aneurysm, and it's really important to have a look carefully at every one of these and make sure it's not a higher up aneurysm that's associated with the anterior choroidal vessel. So this is a lateral view. And you can see it's not easy to see the anterior choroidal artery here. It's overlaid by other vessels. But on the AP view, you'll notice there's this tiny little vessel running in an abnormal direction. So this isn't normally where we'd see the anterior choroidal, because the anterior choroidal should curve around the midbrain. So it should be running in this direction over here. But this bothered me. And when we look at this on a 3D angiogram, you can see it is the anterior choroidal branch, but it is a large perforator branch. And to confirm that, if you follow just this arrow here, here's that vessel coming up, running to supply the basal ganglia and posterior internal capsule. And that's intimately associated with that aneurysm. Here's another example. So this is a patient with a carotid aneurysm coming off where we'd probably call it a PCOM aneurysm, except if we look at the angiogram a little carefully, on the 3D view, here's the little stump of the PCOM that's filling, but the aneurysm is actually associated with the anterior choroidal artery. In fact, the anterior choroidal is coming off the fundus, which is going to make this a challenging aneurysm to treat. So let's leave surgery and aneurysms alone and look at some of the endovascular implications of the anterior choroidal. And I'll show you this example. So this is an example of a AVM post-radiosurgery. And you all knew that because this is a horrible looking little AVM, and it's supplied by the anterior choroidal, but you'll notice that the venous drainage is not typically choroidal. So the venous drainage is into the sylvian veins, and here's something cortical hooking up to the vein of Lavet. So if you look at the AP picture, you can see that. Now, I often hear in meetings people saying that the idea behind endovascular treatment, pre-treatment of AVMs, is very useful to hit the deep perforator supply and the anterior choroidal supply. But from an endovascular point of view, that's extremely high risk and challenging. So this looks like a perfect AVM for endovascular treatment, single vessel supply. Here's a selective run. You can see the anterior choroidal coming up, little nidus, and here's the microcatheter in this case. And you can see the microcatheter is running here through the carotid siphon, comes up, there's the tip of the microcatheter. The tip of the microcatheter is sitting exactly where I've got that yellow arrow, except on injection here, filling the nidus, filling the venous drainage. Here's the AP view. And if I put that in the center of the screen and just enlarge it a bit, you'll see there's the tip of the microcatheter. Here's the choroid of the temporal horn. Here's the transmedullary supply to the AVM nidus. And this is because this is a post-radiosurgery AVM and some of the nidus and supply has closed off, but this is what remains, is this transparenchymal supply to this nidus that's subcortical. This is not going to be easy to target endovascularly. And because the catheter tip is sitting right at the choroidal point, any reflux is going to possibly hit the perforator supply to the midbrain or the basal ganglia, and it's not going to be a safe anterior choroidal to inject. I mentioned as well that the anterior choroidal can have a cortical supply. So this is probably the normal cortical supply that we should see on an anterior choroidal. So this is the medial temporal lobe supply. You can see on the superior view, here's the little supply coming off. But it is possible to have a much larger cortical supply. And this is an example from my colleague Insip Choi. And you can see here on the lateral picture of the carotid, here's the ophthalmic coming off, PCOM filling a fetal posterior cerebral. But as we go up to the anterior choroidal, here's the anterior choroidal, comes up, here's the choroidal point. But distal to that, we've got quite a large cortical territory. And if you look at the vertebral artery injection of the left side, we've got no filling of the posterior cerebral because this entire territory on the left side is taken over by PCOM, PCA, and anterior choroidal. And if we zoom up on this, you can actually see the perforators coming off the anterior choroidal. And here are the choroidal plexus supply coming off that vessel. This is not an uncommon finding. So here's another example, a smaller one. If you look here, this is the little PCOM stump. This is the anterior choroidal with a cortical supply distal to the choroidal point. And again, if you look at the vertebral artery injection, you can see that the lateral posterior temporal branches are missing on the PCA, and that's because the supply is coming from the anterior choroidal. And of course, you can have exactly that variation associated with an aneurysm. So it would be easy to call this a PCOM aneurysm because it looks like that's a posterior cerebral vessel. It's not. It's an anterior choroidal with a preserved cortical supply. And you can see again, here's the right side with temporal supply coming off, left side, no temporal supply because it's coming from the anterior choroidal. Just to show you an operative example, here's a patient with cortical territory given to the anterior choroidal, coiled aneurysm. And in this patient, immediately post-coiling, we thought we'd lost that vessel. So we took the patient to operate to maybe remove the coils and clip. But at the time of surgery, it was apparent actually the aneurysm was nicely thrombosed and the anterior choroidal was preserved. So the final examples I want to show you before I don't want to run over time are again embolizations of the anterior choroidal. And I said for AVMs, it's not a very attractive vessel to embolize because it's high risk, but there are situations where we want to embolize the anterior choroidal, and this is one of them. This is a patient with a choroid plexus tumor. These are pediatric cases. And you can see on the angiogram, there's a large anterior choroidal supplying this tumor. And I mentioned to you that it's possible at the level of the tectum to have anastomoses between the anterior choroidal and the posterior circulation, the posterior cerebral artery, because that's where the anastomosis takes place. And this is an example of that. So we've got a microcatheter in the anterior choroidal artery hoping to embolize this tumor over here. This is the tumor blush. But you can see we're filling a normal cortical territory. And that cortical territory is filling through anastomoses between the anterior choroidal and the posterior cerebral at the level of the tectum. So this wouldn't be a safe place to do an injection. And here's the lateral view. Here's the catheter coming up into the anterior choroidal. We're unable to get distal in this child. So we can't embolize the tumor because we've got a normal posterior cerebral artery filling through the anastomoses that are normally there. Here's a more distal tumor, again, a choroid plexus tumor. Here, and you can see in children, of course, the vessels are very straight. Here's the anterior choroidal. This is the supply to the tumor. Microcatheter placed into the anterior choroidal. We're able to get more distal. There's no normal cortical territory filling, and we can do a good embolization, which is going to make the surgery much easier. And that's post-embolization. Finally, I just want to show you that it's possible to have a lot of anastomoses between all the choroidal circulations. So this is an example of, again, of a child presenting with a AVM of the choroid plexus and thalamus. And you can see here, he has a very dilated internal cerebral vein coming up to join a dilated vein of Galen, which is aneurysmally dilated. Here's the angiogram pictures. So we've got a lateral vertebral artery injection, posterior choroidal supply. We've got a carotid injection with the original choroidal supply, embryonic supply, which is from the anterior cerebral artery, which comes all the way around the corpus callosum into the transverse cerebral fissure and supplies the AVM over here. And then we've got anterior choroidal supply. So this is the opposite, the right carotid injection, very large anterior choroidal coming and again supplying this entire AVM. So what it means is if we're going to embolize this AVM with a liquid embolic agent that we're able to push distally, we have to be aware that when you push it, you can retrogradely flow into all of these territories. So here's the drawing of that again. So internal carotids, caudal division, which is the PCOM going towards the posterior cerebral. And you can see here the medial choroidal and lateral choroidal vessels. Coming up for a little more distally is the anterior choroidal. There's the anastomosis level at the tectum. And here's the anterior choroidal supply to the temporal horn, which is going to anastomose with the choroid plexus of all these other supplies, the posterior and lateral choroidal vessels. And then, of course, the choroidal supply also possible through the anterior cerebral around the corpus callosum, like it is in the embryo. So many pitfalls to the anterior choroidal artery, and an artery that has many territories that are in balance with the middle cerebral and posterior cerebral. So I'm going to stop there. I think I'm on time. Thank you very much for the opportunity to talk.
Thank you very much, Alan Taylor. It's a great talk, really, and I think everybody was interested to follow your talk. I think Hisham Basyouni joined from Germany. Hisham, are you here?
Yes, I'm here.
Okay, Hisham is moderator of this session. Thank you for contribution. I think Hisham, now we move to our next speaker and we can make discussion after the third speaker, according to the program. Would you introduce Professor Jacques, please?
Yeah, I've got, hello everybody. First, I've got the great pleasure to introduce Professor Jacques Morcus, and we know each other, I think, since 20 years now, since my first visit to Little Rock. And yeah, you are going to talk about the cerebral bypass surgery, the technique, outcomes, and lessons learned from the intraoperative flow measurements. So thank you very much, and please, Jacques, it's your turn.
Thank you. What an enormous pleasure to join colleagues and friends in these COVID and post-COVID times. So let me make sure I stay on time. I've got my phone here. Okay. Again, thank you, Nasser, and all of you to putting all these educational things together. So I thought I will share with my friends here and students who are listening in my actually entire career experience with cerebral bypass surgery for ischemia. This is a subject of a paper that we just submitted, not published and not accepted yet. So what have I learned, particularly in relation to intraoperative blood flow measurements? My disclosures are irrelevant to this. And it is a delight to be speaking to, I hope, predominantly African audience. And I love this quote, and it is so true. I am not African because I was born in Africa, but because Africa was born in me, by Kwame Nkrumah. So it is so true for actually everything that we do, whether as humans, as neurosurgeons. We too, at University of Miami, do a webinar. I invite you. These are the upcoming speakers for our monthly webinars. I put the link in the chat box if you're interested in joining us. Each 4 of those speakers are on the 3rd Thursday of each month. And of course, it's all free. And this has been going, we've been doing this for more than a year now. We used to do it actually weekly. Now we're doing it monthly. So on May 20th, for example, is this panel here. And if you want to, you need to register. This is the link. It's in the chat box as well. So I'm going to talk to you about my bypass experience. What was the objective? I looked back at my experience and I analyzed my cases for Moya-Moya disease, Moya-Moya syndrome, and what steno-occlusive disease. Those are the 3 groups we're going to talk about. I wanted to validate the use of direct EC-IC bypass and predict and evaluate the power of intraoperative flow measurements and evaluate long-term patency. And of course, most importantly, how did the patients do? How do their angiograms look? It's about 21 years of data. And of course, I've excluded bypass for aneurysms and tumors. There are three types. I don't use indirect bypass, almost never. It's always direct bypass. I've used three variants: one donor, one recipient, one donor, two recipients, or two donor, two recipients. I'll show some videos near the end of the talk. I keep it simple. It's the traditional way of putting the craniotomy centered 6 centimeters above the external ear canal. You trace usually the parietal branch of the STA. Let's go through a typical Moya Moya example. This patient is African American. She actually is a nurse in a stroke unit of all places. She developed typical stuttering symptoms and strokes at age 32. Here is a typical Moya Moya angiogram. Stenosis of the distal ICA, proximal A1, proximal M1 and A1. She has typical collaterals from the posterior circulation. You can see them via the posterolateral choroidal to the anterior choroidal that was beautifully discussed by Alan a moment ago, and via the PCA to the ACA and MCA. Here is her external carotid. One of the teaching points I'd like the young people to realize: please don't look at the superficial temporal artery and say, oh my goodness, it's so small, I cannot use it for a bypass. Remember, that's how it looks when it's intact in the scalp. Once you dissect it, it opens up. The number of patients I've seen with minuscule STAs that give enormous flow at surgery that's a rule, not the exception. Before every bypass surgery, given that it can be controversial in some cases, particularly since the COS study was published, I always get physiologic studies to back up my decision to operate. So I always do vasomotor reactivity study using transcranial Doppler. It's a nice technique that our neurologists here utilize, and it gives you a number in percentage. It's a measure of vasomotor reactivity. How much can they vasodilate in response to a higher CO2? And this patient's numbers were very low. You want it to be near 60, 70%. Hers were 27% on one side, 32% on the other side. I used to do SPECT with and without Diamox. Now I do CT perfusion or MR perfusion. You can use bold MRI. There are different other ways as well. So I always do these two additional studies besides the clinical history and besides the angiogram in general, particularly for steno-occlusive disease. In Moya Moya, you might say, well, the diagnosis is obvious, but you can learn a lot from understanding their physiology, particularly how much more flow they need. If I can finish this talk later and give you one message, is the importance of quantitative analysis of any patient you're planning to do and you're doing a bypass on. That's the only way you're going to understand that complex physiology. So I proceed with the surgery here, dissecting the STA, both branches, doing the small craniotomy centered on the distal sylvian fissure. Here is Charbel, my good friend Fadi Charbel flow probe. This is measuring, in this case, 3 cc's per minute in the recipient artery before doing the bypass. We cut the STA, we measure the flow in it. It was 60 cc per minute. Then you perform the bypass. In general, I like running technique. If the vessel is very small, I do interrupted. We do the bypass, and then you measure the flow again. And look at this. Remember, the cut flow of the STA was 60. When I finish the bypass, it's actually higher than what it's supposed to give. It's 64 cc per minute due to, so this is so-called 100% cut flow index, following the concept of Fadi Charbel of dividing the bypass flow by the cut flow. And these are the measurements. You can measure how much goes in each limb of the recipient M4. And here is a post-op CTA showing a very nice patent bypass. Here it is on a coronal view. And here she is post-op. And then 6 weeks later, I bring her back to do the other side. And then I do an angiogram for both sides. So you can see it here, post both surgeries, left and right. She returned to working as she's still working. This is 13 years ago. She's still working as a stroke neurology nurse. Steno-occlusive disease, non-moya-moya, is the more controversial topic. I don't have time to go over a critical analysis of the very influential COS study. You can read our rebuttal for that study that our joint CV section did at the time. But we all have these patients. Multiple TIAs, watershed infarct, stage 2 ischemia, due to a cervical carotid occlusion. I am not suggesting we bypass everybody whose carotid is occluded. I'm suggesting we analyze each patient on his or her own merits with physiologic measurements and decide if they need it or not. Many patients, again, I wish I had the time to reanalyze the COS study for you, but I don't. Many patients in the COS study, the randomization time was 72 days, meaning many urgent cases were never randomized. And these are the cases that I still think benefit tremendously from bypass surgery. So here is this this patient who was 76 at the time. He has no crossover from the ACOM, very little collaterals, and that's why he has daily TIAs and watershed infarct of the right hemisphere. Here is a SPECT scan without and with Diamox showing absolutely paradoxical misery perfusion. There is still phenomenon to the good hemisphere from the bad hemisphere. Absolutely, these patients need to be bypassed. Look at his VMR. It is 19%, incredibly low, versus 55% of his good hemisphere. I absolutely have no hesitation to do this surgery on such patients in spite of costs. And I've, of course, have done many, as you will see when I show you the data. So there is a completed bypass, end to side STA to M4 bypass. Here he is. I think he went home 2 days post-op. This 76-year-old died at age 86 from a heart attack, not having had a single TIA since my surgery, having had daily multiple TIAs before it. So what did we look at? So just typical case examples, really. What did we look at in our analysis? We looked at severity of disease, suitability of the donor. We were very interested in degree of collateralization, whether patients were compensated or not. There are 3 sources of collateralization: transdural, or from the posterior circulation, leptomeningeal or PLPL or PCOM, or contralateral from ACOM. So these are the 3 typical examples of collaterals that patients can form. And of course, there are more, also less, more of them in different types that are less common, but these are the 3 most common. It's good to analyze them on every patient. But what we were interested in to see long-term patency, did it matter when we looked at the pre-op angiogram, whether there were bare areas that were not compensated? So for example, this area, when you overlap all the injections, remained an area of hypoperfusion without compensation in this particular patient. We've done it on every patient we could grab, we could identify the pre-op angiogram on in my series. Then we looked at bypass patency. We looked at post-op Matsushima grading of angiographic analysis, the typical A, B, and C grading. How well did the bypass do? This is a typical, excellent, mature bypass. For example, look how big the STA gets over time. This is, for example, 11 years after I did the bypass. You can see the CTA at the bottom there, still looks excellent. Patients are on aspirin. This is a case that occluded, one of actually the few that occluded shortly post-op. There is occlusion, and I took him back to surgery and reopened it with a different anastomosis, And you can see now the patent bypass in the bottom right. These are delayed bypass occlusions. Those are fascinating cases with significant indirect collateralization. You can see the bypass on the left slowly disappearing, the direct bypass, and a robust capillary blush from transdural collateral over time. TCD, as I said, is done based on CO2. You want a normal value to be 70%, and you can see the categories. Most of the patients, as you will see in the data, had very poor TCD VMR. Sometimes we can do breath holding index. During COVID times, the equipment for TCD VMR was not easily available, so we use instead a breath holding index, and there is a nice formula to calculate the index. I'm not going to bore you with, but the normal value should be more than 0.69. We looked at clinical angiographic follow-up. I have done 162 procedures over 124 patients, bilateral disease in 72. Clinical follow-ups is decent. I wish it was an average of 10 years, but it's not. It's very difficult, particularly in our Miami area, to have extremely long follow-up. So the mean follow-up is almost 3 years. I have range up to 21 years. I have angiographic follow-up mean of 1 year and 9 months with range up to 12 years. Of course, my practice became busier as I became more experienced and established. In the first 7 years, I only did 14 cases. The next 7 years, I did 41. And the last 7 years, I did 107 cases. I divided it, moyamoya disease, moyamoya syndrome, and steno-occlusive disease. I know there is no time to go over the individual demographics and the data points, but just to show you that I've really analyzed them based on their etiology, their comorbidities, and hopefully you will see all this data in print. I've done, again, all of the analysis I just described. So here is interesting. On the mean VMR in my patients, I want to show you that I really did choose appropriately. The patients was 29%. So that is a very low VMR pre-op and a low breath holding index. Now, notice this, in spite of clinical success and angiographic success, VMR doesn't improve very much. So that's an interesting thing we're looking deeper into. It's the mean VMR post-op was 39%, pre-op was 29%. SPECT analysis, I'll skip over. Some more details I can skip over. The surgical morbidity, I would say there was a 10% significant 30-day surgical morbidity. What does that mean? Ischemic stroke only 0.6%, intracranial hemorrhage 3.1%, subdural hematoma 1.9%, some wound complications, some respiratory failure, and 1.3% of MIs. This is a detail of the 6 cases that had post-op stroke or hemorrhage out of the 162 cases. I'm sorry, but there is no time to go over each detail. And this is a very novel finding, not surprising. If the patients had complete collateral formation pre-op, there was a delayed occlusion of the bypass, delayed, not acute, in 36%. But if there was incomplete collateral formation, only 4% occluded in a delayed manner. So this is shown in graphic format, occluded. You can see the orange are the ones who had incomplete collateralization pre-op. Their bypasses, make sense, stayed open essentially almost permanently. Clinical outcomes, this is what matters. The patients got better. This is modified Rankin score. You can see the shift from the blue pre-op to better modified Rankin score in orange post-op. We are helping patients with these operations. These are the 3 types of ways we do it. As I said, I call them 1D, 1R, one donor, one recipient, 1D, 2R, or 2D, 2R. You can see the patency rate not statistically significant, but a trend for better long-term patency if you use 1D2R or 2D2R. And you can see the MRS at the bottom, and you can see the cut flow index gets higher and higher the more you do a 1D2R or a 2D2R variant. I have a separate publication that is in print analyzing my 1D2R cases in the Journal of Neurosurgery, should be coming out more, and it discusses in great detail how we measure the flow measurements. When you looked at the delayed bypass occlusions, of course, I'm interested to know, why do some patients asymptomatically, years later, gradually lose their bypass? There are only two factors. One of them I cannot explain. Hispanic race was more associated with a delayed occlusion. And as I mentioned, the collateralization on a pre-op angio, that one makes sense. I cannot explain the Hispanic race. Of course, it could be complete randomness, but nothing else explained it. So I'll show you 1D2R example. I think I am getting very near my time. This is a video. I thank my former fellow, Georgios Zenonos, to just show you the technique of this. This is Moya Moya. So I am going to take, I use the Colorado needle or the bipolar to skeletonize the donor STA. I like to use the ICG to show the STA. Here it is, ICG, and then STA cut flow in this case was 50 cc per minute. We are going to do the simple round craniotomy. We're going to isolate both a temporal and a frontal M4. I like to put this suction device. We're going to, you can do an end to side on one vessel and a side to side on the other. This example I'm showing you is showing the end to side first and side to side next. But in general, I do it the other way. It makes more sense to do it the other way, which is side to side first from the STA and end to side next, because when you do the end to side, the side to side anastomosis would be flowing. Here is ICG. We do, I think I'm doing interrupted in this case. I'm not going to waste your time with suturing. End to side is finished. Measure the flow. It's 43 cc per minute. Notice what happens when you do the second anastomosis. Side to side from the same donor, STA. Remember, the number I said is 43 cc per minute. Now, after finishing this side to side, it will go up. Of course, it will go up because you're giving it less peripheral vascular resistance. You remember Ohm's law of electricity. It's absolutely the same thing here. Delta V is equal to QR, and the flow will be 60 cc per minute. I bumped it up from 43. And this is higher than the cut flow. Remember, the cut flow was 50. So we went from 50 down to 43 and up to 60 by doing a double anastomosis with the same donor. Here are the numbers again, and the craniotomy is closed. Here is a post-operative angiogram. Patient did very well. I don't have, if you don't mind, I'm gonna stop the slides and perhaps take you to the conclusion here. I wanted to compare our series to my good friend Fadi Sherbel series because there is a discrepancy. Fadi from UIC and Sepi Hanjani published their series and showed cut flow index, that the cut flow index predicted long-term patency. I cannot find that in my series as I showed you. And again, hopefully when it's in print, you will be able to read the discussion in detail, why I think the two series are different. I think it mostly has to do with the fact that the Sherbel and Hanjani series, they use concomitant EDAS with their direct bypass. I don't. I only use direct bypass. We have a long-term patency rate of 91%. Fadi's long-term patency is 76%. I don't think it's an indication of any difference in technique, but I think it's a concomitant use of the indirect bypass. We'll skip that. So discussion, clinical outcomes, bypass surgical patients that I've presented to you, 162, did much better than their natural history would have done. 5-year cumulative stroke rate of 82% if we had not done the surgery. Excellent long-term patency of the bypass of 90, 91%. Post-op morbidity, much better than the COS study. Much, much better. Death 0.6%. And I will stop here, and I thank you for your attention.
Thank you very much, Jacques. Great as usual. Presentation very simple, very illustrative. I think it's a good opportunity for young neurosurgeons and for all of us to learn from your great experience. Thank you very much. I think now we have some questions over the chat panel and in the Q&A, but we now move to the third speaker, Professor Ahmad Hijazi, and to see the Egyptian experience in bypass surgery, and then we open panel discussion.
Well, thank you very much, Dr. Nasser, and I truly am honored to be among the distinguished guests over here. Can you see my screen?
Yes, it's perfect.
Very good, very good, very good. I'm very happy to be able to share our experience with ECIC bypass. We've started doing ECIC bypass here in Egypt, particularly at Cairo University in 2006 and 2007. I was originally trained by Dr. Dolenz, and although I did not learn bypass surgery from Dolenz, yet the principles that he would install in us surely did carry on when we tried to attempt doing bypass surgery. I learned bypass from Peter Schmiedek in Germany and from Dr. Shaker in the United States. I've also seen Dr. Jacques Marcos once in 2009 in St. Louis, but this is an opportunity for us to tell you our insights on ECIC bypass surgery. You know, of course, that before 1914, there was no vascular surgery, and vascular surgery was introduced in 1914 by Alexis Carrel, who managed for the first time in the history of mankind to perform successful end-to-end and end-to-side anastomosis, and he described the triangulation technique that actually we do use up till now. This procedure kept on developing, and he was awarded the Nobel Prize in the beginning of the 20th century for inventing vascular surgery and for pioneering transplantation, which had started to occur as a result of the bypass surgeries. But from 1914 up to 1960s, it was not possible to perform successful anastomosis on vessels less than 2 millimeters in size. And because actually the operating surgeons did not have the opportunity to see adequately inside the vessels in order to perform the anastomosis. So with the introduction of the operating microscope in the early 50s and the 60s, Dr. M.G. Yashergil performed the first STA-MCA anastomosis in 1967, actually at New Year's Eve. When we started doing this, we decided first of all to do this first in the lab, and we realized that we will not be able to perform the surgery successfully unless we had a 100 or at least 98% success rate in the lab. And that's why we started performing practically thousands of microvascular procedures in the lab on lots of animals. We used rats and we used canines. And this took us approximately 4 years of preparation in order to make sure that we do have a considerable success rate in the lab that would allow us to perform these complex surgeries on human beings. It was quite difficult in the beginning because we did not have the setup that would allow us to perform these surgeries. But we did invent a lot of ways. One of them was the use of intraoperative fluorescein angiography to document the anastomosis. Then in 2006, we reported our first cases of ECIC bypass, which was an initial series of approximately 20 patients. When we started operating patients with bypass, we started first operating patients with steno-occlusive disease, patients mainly with total internal carotid artery occlusions. And also we started doing high flow bypasses. At that time, it was not really well known because most neurologists did not really believe in the fact that Moyamoya disease does exist in Egypt. Until we started to collaborate with a very eminent strokeologist in neurology, Dr. Fuad Abdallah, who's a leading stroke neurologist in the Middle East, and he started to perform vast series on patients with ischemia, and we realized that patients with Moyamoya disease do actually exist. And ever since we started operating patients with Moyamoya disease, we've been getting more and more patients every year. And the number of cases has changed over the years. We started first operating patients with steno-occlusive disease, then the number of patients with Moyamoya disease started to increase. And finally, actually recently, we don't operate as many patients with ischemia as much as we operate patients with Moyamoya disease, in addition to patients with high flow bypasses. Now, for some cases, these were some of the very early cases that we've operated. This was a 56-year-old male patient who presented with hemodynamic ischemia. He had a complete carotid occlusion, and he was referred to us because of persistent TIAs and failure of medical treatment, and he did not have any major neurological deficits at that time. So this is the technique that we use for the dissection of the STA. Usually we use the parietal division of the STA, but this will depend upon a lot of factors. The parietal division is the most favorable branch to be used. The donor is being prepared, as you can see, and then the recipient vessel is prepared. We use the M4, but I have used M3 cases, and some cases I've also used the M2 to perform the bypass, because it is essential that there would be no donor-recipient mismatch in such cases. I always use an interrupted technique. I never use, for low-flow bypasses, I always use an interrupted technique. And this is something that I would like to point the attention to, that for low-flow bypasses, because of the small caliber of the blood vessels, I always use an interrupted technique, because with continuous suturing, it does not really allow that much for the development of what is known, the process that is known as graft maturation, because continuous suturing techniques will usually have a purse string effect. And for low flow bypasses, this could prevent the anastomosis from growing. So I've always found the interrupted technique to be more useful. And I've had very good long-term patencies with these cases. But for the high flow bypass, it's a completely different ballgame. For high flow bypasses, I always use a continuous suturing technique. One thing that I would also like to point in these cases is that finding the recipient vessel in these cases needs experience. So to start with, you have to be able to do the anastomosis very well. And then after doing the anastomosis, you have to gain intraoperative experience, because you need time in order to find the adequate recipient that would be the most useful recipient for the patient. We don't have intraoperative angiography or fluorescein or ICG, so we do have to depend on the clinical observation. But one very known fact in microvascular surgery is that a good anastomosis will always persist. And that is why when we started working in the lab, we would not sacrifice the rats before 6 months. So we would use the rats and we would keep them alive up to 6 months before we sacrifice them and we start testing the anastomosis again. This is a very valuable tool that we are using throughout the process ever since we started and up till today, which is the transcranial color-coded duplex, the TCD, because it does give us a very adequate quantitative idea about the function of the anastomosis. And it doesn't only tell us if the anastomosis is functioning or not, but it tells us how much blood is flowing inside the anastomosis. We found this tool to be very useful, especially post-operatively, because of the presence of the open window, of course. And then we started, after gaining some experience with low-flow bypass, we started doing high-flow bypasses. This was one of the first patients that we've operated for high-flow bypasses. Was a 19-year-old male patient who had a massive aneurysm of the internal carotid artery in the cavernous portion of the artery. And actually, because of the massive size of the aneurysm, this boy had presented with facial paralysis, with conductive hearing loss because the middle ear had been destroyed by the massive size of the aneurysm, and in addition to TIAs, of course. So we've discussed the possibilities with the patient, and we went in to have a high-flow bypass for this guy. We always use a radial artery. I've never used saphenous vein in my whole life. I've always used radial artery, and it served me good. And because I actually use the pressure distension technique constantly with radial artery, I've not had any patients who've suffered problems because of vasospasm, which is commonly known in the cardiothoracic surgery literature and in the general surgery literature. But ever since the pressure distension technique was introduced by Dr. Shaker in the early 2000s, we have not had in our experience any patients who suffered actually spasms. The radial artery, we try and take the longest graft possible from the radial artery. We take the radial artery actually from the anatomical snuff box all the way to its origin from the brachial artery. And as you see, we mark the radial artery so that we would make sure that the artery does not twist while being passed through the tunnel that we create from the neck all the way to the brain. This is an exposure, as you can see in the neck. This is the common carotid artery and the internal carotid artery. And this is the anastomosis itself. I always use the M2 division, whether the frontal branch or the parietal branch, any of them is fair game. And whatever branch I have available, I would use so long as it's long enough and so long as it's not deep enough. I usually take it as close as possible as it would be to me, because I would like to bring the anastomosis closer to me as much as possible. And I ligate the perforating vessels that come out of the M2. We have not suffered any problems because of these. And usually you're very lucky when you have a long segment of M2 that you can work with. I never used any retraction, as you can see. And it's the same technique as in a low flow bypass, except that this is performed in a deeper field. And the vessel is prepared exactly the same way. But the only difference over here is that I always use a running suture technique to perform the high flow anastomosis. And with the radial artery, actually, it's a lot easier because the vessel caliber is much bigger than it would be with a low flow bypass. And the anastomosis is created. Usually we do not have problems creating the anastomosis in such cases. And then we use a hand-on-hand technique in order to tighten the anastomosis. This is one of the early available pictures that we've had following performance of an STMC anastomosis. As you can see, the radiologist could not explain what he was seeing at that time because he was telling that he was seeing the superficial temporal artery passing through a craniotomy and is providing good flow to the hemisphere. And it took us some time to convince the people around us that we are performing these procedures and that they do actually do good for the patients. Again, I always use, this is a problem that we've had actually with patients with high flow bypasses, because with graft maturation that takes place over time, sometimes these anastomoses usually would push a huge amount of blood inside the brain. This is a patient who's had a TCD measurement of more than 250 milliliters of blood per second. And I've asked many of the people around the world what to do in these cases, because this was the only source of blood supply to this hemisphere because of the carotid ligation that we've performed in this high flow case. And nobody really has the answer what to do in such cases, because these patients suffer tremendous headaches and the hemisphere is actually congested at some times. But up till now, those patients, they tend to accommodate this after some time, but I don't think that we have a solution for that. But anyway, it does entail the success of the anastomosis. This is the initial series. It was around 100 cases, and right now we've actually surpassed 400 cases of patients with bypass. We've had one patient in the beginning of the series who suffered from a hyperperfusion syndrome, and this was catastrophic and the patient died. And at that time, we did not know how to deal with hyperperfusion, but later on, we started doing using Trandate routinely on these patients, and it's helped us a lot. We have had 2 patients with bypass occlusions, but we did not have any other patients with bypass occlusions, and most of the occlusions that did occurred actually within the first 2 or 3 days following surgery. We do not recall having patients with delayed occlusion that would take place years after the anastomosis, probably because we don't have such long follow-ups, probably, I don't know. But this is not our experience. This is a case that I was telling you about, a patient with a massive aneurysm of the skull base that we've operated with a high flow bypass. And this is the post-operative angiography showing that the hemisphere is completely filling from the radial artery graft that we've placed. Again, the TCD is always being used in these cases. And these are some of the pictures that we've published because we've published a number of articles on our experience with bypass. This is one of them. This is another one of them. And we hope that in the future, we would continue to share our experience with the rest of the world as concerning ECIC bypass. But it is becoming quite difficult after the publication of the cost study in 16. Because after the publication of the cost study, it's become quite difficult to recruit patients with steno-occlusive disease because of the referral, of course. But we do continue to operate patients with high flow bypass and patients with moyamoya disease. But for steno-occlusive disease, it's becoming more and more difficult every day. Although the CAST study was not the best study in the world, yet it cannot be denied that it was a well-designed study and that study was well carried out. I personally believe that the problem with the CAST study was the high rate of complications that had taken place. And but on the other hand, I would really think that the benefit that comes back to those patients is much bigger than the rate of complications. And we have not, in our experience, had this massive number of complications that had been described in the CAST study. I don't know why, but I think there's some form of bias in this case. Thank you. Thank you very much.
Thank you, Dr. Ahmed Hijazi, for this great talk. I think now, Hisham, it's time to have open discussion, and also I can see many questions in the Q&A and chat panel. Would you moderate the discussion, Hisham, please?
Yes. Thank you very much for these very interesting and very practical presentations. And I'm looking if there are, I see there are questions. Excuse me?
Hello, sure.
Professor Osama Al-Ghandour would like to make a comment. Professor
Okay.
Osama Al-Ghandour is Honorary President of Egyptian Society of Neurosurgery, and he is former Dean of Faculty of Medicine of Azhar University. Professor Osama, go ahead, please.
Hello, everybody. I must thank you for taking the hassle of arranging this webinar in such Ramadan. And I must confess to you that I enjoyed listening to the three papers. But I have just a little comment for both speaker, Professor Alan Taylor and Jack Marcos. When you do embolization for choroid plexus papilloma, whatever, even malignant ones, which are very rare, and we have a humble experience of that, we don't really do any embolization, just go directly to the one arterial supply coming from the choroid plexus, and that's it. So, but if you touch the tumor before reaching the main supply from the choroid plexus arteries, choroid plexus itself, you will have a hell of bleeding. This is my first comment. A second comment about Professor Jack Marcos. I admire the double way of anastomosis. I've been learned that long time ago to do end to side just once, STMCA to MCA. But now you open my mind that you can do doubling side to side, and the final end of the RT go to end to side, which is, I think, improve a lot. Thank you very much indeed, both of you.
Thank you, Professor Osama. You'd like to say any comment, Professor Jack?
Yes, thank you for your Osama for your comments. Yeah, as you will see in that paper that's in press, the 1D2R, what I'm calling 1D2R, does offer advantages physiologically. I do want to warn the young people, it's not something that you start doing from first year in practice, because obviously if you screw up the STA, you've lost both anastomoses. I think it requires some experience under your belt before young people start doing it. That's my only comment or warning about it. But yeah, it's the advantage of not having to dissect the anterior branch and ending up sometimes with scalp devascularization and added operative time is tremendous. And you leave the anterior branch, you never know, you might need it years later for failed bypass, you still have it in reserve. Many good advantages. Thank you.
Thank you very much, Hisham. We have many questions in the Q&A.
Yeah, maybe just one question which was not answered yet about the choroid plexus papilloma. Maybe you can answer this, Professor Allen.
Sure. Professor Sama, I think you're completely correct. Of course, it's possible to operate on these tumors. The examples that I showed were both very young children where actually there is concern about blood loss, and it isn't always possible to get directly to the choroidal supply in patients that have very large tumors, and that's the reason for that we attempted embolization in those two patients.
Well, I agree with you. I've seen one of your cases. There is probably one of them. It looks like aneurysm of vein of Galen. We can't touch that. This is yours, definitely. Is it right? You can't, we stop doing surgery for aneurysm of vein of Galen.
Oh yes, yes,
and this I think needs your help.
Yes. So as I said in my talk, I prefer to call that a choroidal AVM that's draining into the vein of Galen. To separate it, it's not a vein of Galen aneurysmal dilatation. So I think this patient has not an aneurysmal malformation. I think that was more a true AVM of the choroid plexus extending into the thalamus, which you could see on MRI. Unfortunately, I didn't have time to show all the images for those patients.
So
thank you very much indeed.
What is the sequelae of bypass in long term, and how would you like to follow these patients, and with investigations?
Please introduce yourself first. I think he's our colleague from India. What's your name?
Uday Gupta. Uday.
Okay. What's your question, Gupta, please?
So what is the sequelae of bypass in the long term, and how would you like to follow these patients, and with which investigations?
Your question is Professor Jacques Morcos?
Yes.
Okay.
I always do immediate post-op angiogram. If I'm planning a Moya second bypass, I don't put the patient through 2 angiograms. I wait till I've done the second side, then I do an angiogram of both sides, and then I follow with CTA. Of course, with CTA, it's so simple with nice software to reconstruct in 3D. And I like to follow them years and years. I mean, you know, and we do once or twice TCD VMR because I'm mostly interested in understanding their physiology. But CTA is the main thing. There is no need to keep doing imaging if the patient is doing well. But one long-term CTA would be very helpful.
Thank you very much. I think we've got some questions here. First one I see is from Mohammed Helmi, and it's to you, Jack. I just read it. As we may have a retrograde flow from the collaterals in the proximal occluded MCA, the pressure difference delta P will be higher in the downstream point. I'd like to ask whether the location of STA MCA anastomosis matters in reducing the delayed occlusions.
Yeah, very smart and very relevant question. At least theoretically, and again, I encourage you to read the 1D2R paper coming out in press. It goes exactly into the modeling of all those flows and the peripheral vascular resistance and the flow. In practical terms, you want to do the bypass on the surface. You don't want to generally do it in the sylvian fissure. It's harder. You may end up with more flow than you need. So in theory, your question is very important. In practice, it's not, because you're going to go to an M4 branch anyway, as close to the sylvian fissure as possible. When I first started doing bypass, I used to actually take a 25 gauge needle, attach it to a pressure line, an arterial line, and measure pressure inside the recipient artery. And then that hole was helpful in being the first arteriotomy site. I just wanted to measure both pressure and flow so I can calculate resistance. After a while, it kind of became unnecessary. But yes, but in answer to your question, of course, you get different pressure measurements depending how distally you are. In practice, I don't think it makes a huge difference. Bypass as close to the sylvian fissure as you can, but still staying in an M4 if you find an M4. If you don't, Go for an M3, yes, no problem.
Thank you. There's another question from Cerebrovascular. What is the criteria of vessels which will be used for the bypass? There are criteria, of course, but maybe this also.
Maybe we can ask Dr. Hijazi to answer that question.
Well,
Ahmed, you want to take it?
yes. This depends whether on you're talking about a low flow or a high flow bypass, actually, because with a low flow bypass, which is mostly the ST-MC anastomosis, you would go for the larger caliber division, because in our experience, this is usually, in our population, usually this is the parietal division. And not only so, but the parietal division of the STA has always been found to overlie the best possible cortical recipient. So the parietal division of the STA would always be in line with the best cortical recipient. You don't really have that much choice over the recipient, because you're looking for the recipient that would be closest in caliber to the superficial temporal artery that you're using. And also, according to the dexterity of the surgeon, you want a recipient to be in line with the artery itself, because you want to make things easier for yourself. But again, if you cannot find a suitable M4 branch on the surface, then you might have to go for an M3 branch. In any case, sometimes you might even have to go for an M2 branch, but it is extremely essential that you dissect the longest possible graft that you can use. This is very important, that you would have the longest possible STA, so that this would give you an opportunity to use whatever cortical recipient that you would find in performing the anastomosis. With high flow bypasses, it's different, because with high flow bypasses, we've only used the non-dominant radial artery in all cases. We have not used saphenous vein, and we have never used the dominant radial artery, because this is the cardiovascular experience, and I think it's served us pretty well. So the caliber of the blood vessels is essential. You have a choice with the STA, but with high flow bypasses, you don't really have that much of a choice. I hope this answers the question.
I think Mahmoud Qurashi would like to make a comment. Mahmoud, are you here?
He's muted. Mahmoud, you're muted.
Mahmoud, would you unmute your mic, please?
He's unmuted, but no sound.
No, we can hear. Ahmed, IT? Dr. Nos. Would you unmute Professor Mahmoud Qurashi from your side, please, if you can?
Hello, can you hear me now?
Yes, now it's good, yes.
Okay, I obviously have no experience in the kind of surgery that we've just been listening about. Having said that, it's gratifying to see that on the continent now, this cerebrovascular surgery coming on. And from a CADS perspective, you know, Nasser, you and I have been discussing about the development of subspecialties on our continent. And I'm wondering whether this is not an opportunity for folks like Alan and Ahmed to put together a cerebrovascular committee, because there are many young neurosurgeons on this webinar who are wondering how they will, in 20 years' time, be where Jack Marcos is. And I know one of the dilemmas that Alan has is what is going to become to microsurgery and cerebrovascular surgery in the coming years. So I would like to make a plea that folks like Ahmed Hijazi and Alan Taylor initiate that on our continent. And I know that Jack Marcos would be hopefully, and I know he will be willing to be supportive of this initiative from a development point of view. So I'm just making a philosophical comment.
Thank you very much, Mahmoud, and it's good initiative, really. And
Dr.
now,
Mak, I would like to mention something.
Yes, please.
Regarding the best donor vessel, because the STA for a neurosurgeon is usually a very good vessel to use. But the problem is that we've had some patients who have had not only an occlusion of the internal carotid artery, but we've had patients who've had also an occlusion of the common carotid artery. And this becomes very difficult because these patients will have very poor flow in the STA. And we usually do not want to use high flow bypasses for patients with ischemia because of the fear of the massive hyperperfusion that can take place in these cases. So we've had cases in which we've had to first revascularize the STA itself. And I remember that one case we used a subclavian artery to a superficial temporal artery graft in order to revascularize the STA. And we left the STA for a couple of months. And then when we confirmed that there was good flow in the STA, we went in and we used it as a graft. So for a neurosurgeon, I think the STA is a very beautiful donor vessel, and it usually has a good and adequate length, and it's not such a low flow vessel because in time the graft maturation allows it to be actually sometimes even a high flow graft. So I would always say STA, STA, STA all the time. So that's one thing that I just wanted to add.
Thank you, Ahmed. Really, Ahmed is doing a very great job. He is my colleague in the same center. We are working in Cairo University. He's educating many young neurosurgeons, either from Egypt or from Africa. And we have a separate cerebrovascular unit, which is existing in the Department of Neurosurgery at Cairo University Hospitals. And Ahmed can say now that we are operating on aneurysms on emergency basis. We don't wait. We can be operating on the same day or next day. And we are doing all types of cerebrovascular surgery in Cairo University and in many centers in Egypt. Thank you, Ahmed, very much. Hisham, do you have any more questions?
Yes, one from Sahir Shah from Afghanistan. And he's giving this question to you, Jack. It's how can we control the blood flow pressure if there's a difference between the donor and recipient arteries?
Well, you cannot control it once you put it. What determines, the formula delta P equal Q times R, what determines the flow is really the peripheral vascular resistance. You cannot control that. You can modulate the blood pressure of the patient, of course, so you can control one part of the delta P, which is why some of those hyperperfusion injuries that are seen can be very frustrating. They are rare. I showed you my data. They are rare. And that's why you don't want to do the so-called high flow. By the way, I'm sure Ahmed Higazi will agree with me. It's misnomer to use low flow, high flow. I join my good friend Charbel in saying we should not use low flow for STA-MCA. In my data, some STAs had flows of 160 cc per minute. So that's not low flow at all. We should use the term low capacitance vessels. So the radial artery is a medium capacitance vessel. The saphenous vein is large capacitance vessel, and STA is low capacitance. What determines the flow is the vascular resistance and the delta P. So I actually agree with Ahmed, so that STA is more versatile than you think it is. I've taken complete carotid arteries, strapped them, aneurysms, and replaced sometimes with STA only. You don't need radial artery and saphenous vein every time, as long as you measure flow intra-op. Otherwise, you're flying blind. You have to measure the flow. It's a simple math problem. You measure the flow, you do the subtraction of what's needed when you apply the temporary clipping. You measure the STA. Can the STA, again, I'm not saying anything new. Fadi Sherbel has published this, the FAST technique, many years ago, and it makes perfect sense. What astonishes me is how little it is used around the world. And it just, this is the only way to analyze these complex cases.
One thing I would like to add with the STA is that you know, ever since I started doing bypass, and I've been called upon repeatedly to save the day in patients with various pathologies where a sudden rupture of the ICA had taken place or the MCA rupture had ruptured in these cases, and they would call me in to do a bypass in order to save the patient. And the problem in these cases is that usually the craniotomy is being done by a junior neurosurgeon, and junior neurosurgeons, while doing the craniotomy, would usually sacrifice the STA first thing that they do. So they start first thing by sacrificing the STA. And then when I'm called in order to perform an anastomosis in these cases, usually there's no STA to be used. So it is essential that we train our young neurosurgeons that the STA is a treasure that they would have to preserve. This is very basic, and this is very important because it can save lives. Because what happens in most of these cases when you go in to save the day and there's no STA, then you'll have to wait and start dissecting the carotid artery in the neck, and then you have to take a radial artery graft. And this takes an enormous amount of time compared to the STA. The STA is very near, it's close, it's available. You can use it anytime, and it can very easily save the day, not just in patients with vascular pathologies, but also in patients with tumors, patients with clinoidal meningiomas, phenoid ridge meningiomas, and whatever. Because every now and then you'd have a neurosurgeon who's had an intraoperative catastrophe, and you cannot really do anything to save him because simply they lost the STA first thing in the morning while opening the case. So I guess it is very that the young neurosurgeons would be trained to treasure the STA. The STA is a very valuable tool, whether you're doing an aneurysm, whether you're doing ischemia, or whether you're doing something else completely different. Please try and preserve this thing. Thank you very much.
Thank you, Ahmed. Professor Alan Taylor, what's your opinion?
Yes, I think those are all perfectly good comments. I don't do bypass surgery myself. My career has taken a different path with endovascular surgery, so I don't have much more to add, but thank you.
Thank you very much. Hisham, would you like to move to our next speaker, or do you have any more questions or comments?
No comments, and thank you very much. So we begin the second part of this webinar. It begins with the presentation of Professor Ahmed Ammar from Saudi Arabia about cavernous angiomas and the strategic plan for their management. So please, Professor Ahmed.
Thank you very much. Thank you very much for the invitation, and I would like really to acknowledge the great success of this series of webinars, which organized by Dr. Nasser El-Ghandour and his team, and it is a great add to the neurosurgery in Africa. And also it is a great honor for me to be among this great speaker, great friends like Jacques Marcos, Alan Taylor, and the others. Well, you know, I enjoyed very much the discussion of the first session, and in fact, we have learned a lot. Now I'm really joining to talk about something more practical, but also touching that is the core of medicine, about the philosophy and ethics. So, of course, I have nothing to report, to disclose. We have to remember always that is the aim of any medical treatment, any methods, which are going to have always new methods at every time, that it is offering the right management for a right patient in the right time. And that management should be accepted by the patient and should also provide the best possible outcome. That is the philosophy of the basic philosophy of medical practice. Because this is important now, because actually for every procedure, we have several methods. When we talk about making a decision for which you are going to choose which method for which patient, or what you call a strategic plan for the management of certain disease for certain patient, we have to see, first of all, we have to have facts. Good decision is based on good facts. Otherwise, without, as Marcus was saying, that is, you will be driving in blind driving if you don't know actually the flow. So that is, you have to have real facts as much as possible before making a decision. Then you have to study all the factors surrounding, either patient, general condition factor, patient instrument factor, the nature of the disease, and so. And that is, these are actually, when we talk about cavernous angioma, it is presenting all of this. Because presenting cavernous angioma, there are many things, many factors in it. It is either the cavernous angioma or CCMS, cerebral cavernous malformations, are discovered incidentally, or it's presented as epileptic case, or it is presented after hemorrhage. And also, so this makes a big difference when you decide to operate or to treat this patient. Also, it can happen, as you will see in our cases, in neonates, and it can happen in old patients discovered there, and different general condition. Family history, actually around 60% of the cavernous angioma, it runs in family, especially that is Hispanic descent, but also I believe in the Middle East, in Arabic, we have also the same, maybe the same roots. Location, cavernous angioma is also very different. That can be everywhere, can be in the brainstem, can be in the orbit, can be in the deep structure, can be in the spine, as you see. Then also factors which you make the decision, the facilities and your personal experience, or the surrounding, or your colleagues' experiences, or the facilities in this. Then the most important thing, which sometimes we don't really, we put it in the end, rather than it should be first, patient autonomy. When we say patient right to choose a treatment, it is patient right, it is ethical, it is fundamental, but before making also, asking the patient to make a decision, he has to know the factors, all the facts. He has to know the prognosis, he has to know the nature of the disease, he has to know the several options of the management, what is available and what is not available in this place, and if it is not, it's what's available in other places, and he has to know everything. Then you ask the patients to accept or not to accept the management. So this is actually, it makes us help about what we call, that is evidence-based medicine, helping us to really to think about which method can be better, rather than it is limited. And there is also a lot of challenge for evidence-based medicine nowadays, but it is in neurosurgery, we talk about, there is evidence sometimes this method may be better in such situation. But also values-based medicine, which is introduced as ethic, that is what goes around, that is everything should be done for the sake of the patient. And actually the patient should be a partner of the treatment. So the challenges of cavernous hemangiomas it is the most common vascular malformations. It is different presentation, as I said, different location, different sizes, different ages, different outcome, and the management also varies, and also the genetic cause, which really has a great impact on the management. And if you go to the literature, you will find several classifications based either on hemorrhage or based on the location and based on other things, and then the patient time. So incidence, I'm going quick about this, incidence of cerebral cavernous malformations. It is rather between 0.4 or 0.5 to 0.8%, and they say that is making up about 10 to 25% of all vascular malformation. The annual risk of hemorrhage is between 0.7 to 1.1% by lesion, which no history. And also, it seems that is superficial cavernous malformations, malformation have lower risk of bleeding than the deeper one. But it is interesting also, there came studies say that this female patient have worse prognosis than male patient. Actually, in our series, we didn't notice this, but this is something about to mention from the literature. This is some of our cases, which will go on some of them. You can see that it can be in the orbit, last one we had a few weeks ago, and it can be in the bones. It can be small or can be very large like this. It can be in spine, either in dorsal spine, and it could be in cervical spine like this. So you can have different. It can be large cavernous angioma, or can be very small, deep cavernous angioma as well. So this is the varieties of the sizes and the locations makes us think it is not one method to treat such cavernous angioma. We have to consider many different ways. So the genetic causes as well, that is what should be studied with every case of cavernous angioma. Now it is proven that CCM1 and CCM2 and CCM3 are really three genes are individual with inherited type of cavernous angioma, and also that is the mutation of these three genes account for 70% to 80% of cases of familial cerebral cavernous angioma. The remaining 20% to 30% of cases may be due to other unidentified genes or to other unknown causes, like people talking now KRIT1 or BDCD10 genes or others. So just for our young people, that is intracavernous angioma are vascular anomalies consisting mainly of endothelium-lined covers filled with blood at various stages of thrombosis and organization. And when you open to remove the cavernous angioma, in most of the time, you find the gliosis around it stained, xanthochromic, as it is always a degree of leaking of the blood in the surrounding tissue. This is just the histopathology of large thin wall blood vessels, which shows that is a fibrocollagenous stroma of the cavernous angioma. Now we will talk about cases, more or less, just to highlight what I mean by different location, different sizes, and different technique, and also patient tries to decide what to do. This is a report, this is a personal report. It's not many, but they have my personal cases, 67 cases in over the last 20 or 25 years. Actually, I have 6 of them in the brainstem, 7 posterior fossa, but the majority definitely, as goes with the literature, in the supratentorial. We have 3 in the orbit. We do them with ophthalmologists and do 7 multiple cavernous angiomas, one which growing, which I call it growing. This is a familiar type of cavernous angioma with multiple cavernous angioma. As much you operate the patient 1, 2, 3 times, and after years you find another cavernous angioma coming up, and we will present a case because this is a dilemma. You don't know what to do with such cases, and we have spine cases as well. So this presentation also differ. Actually, nearly half of them presented with epilepsy, with no history of bleeding. Part presented with bleeding. And actually, I didn't have one of my, on all my cases, that is a fatal bleeding. That is a large amount of bleeding, which causes really mortality of such kind. It is bleeding, which can cause neurological deficit, but it's always that is can be treated or removed or dealt with. We have exophthalmos 3 cases, but we have also asymptomatic 7 cases. One of them actually was a doctor, was us. and she was a female doctor. And she, for another reason, she did a CT, she did a brain MRI, and then because another problem, and we find that she had a deep temporal cavernous angioma. So the age, as I told you, is varies from these cases. Also, the female to male in our group, almost the same, so male slightly more. And in our patients, there are 58 patients who were operated upon. 3 of them have been operated more than one time. 11 patients refused the surgery and treated symptomatic as treated with anti-epileptic drugs. And actually, they are doing well. And one of them I am following for over 20 years without any troubles. But we have actually 3 special families. They are Saudi original, they are not mixed, and they have, this is the genetic mutations in them, and one family, I operated 5 people from the same family, all girls, all ladies, and that's strange, all ladies. I operated the grandmother, the mother, the daughter, the cousins, and 4. And another patient completely different, they have 3. They are males, 3 males in the same family operated by cavernous angioma. So I get, just to go an example, this is 22 months old baby. He came to our hospital. Actually, he was transferred from Kuwait. He was not, and he came with unconscious and intubated and with multiple cavernous, cranial nervous palsy. And that was his picture, large cavernous angioma in the brainstem, in the bones, and that is when we operated through the midline safety entry zone as described by Kobayashi on the floor of the first ventricle, and then we removed and washed clearly. And actually this is the MRI before and MRI after, and the patient did well and extubated and left the hospital after actually more than 2 months. I have another case of also pediatric. 4 years old girl suffered sudden attack of severe headache and right side hemiparesis. Patient was brought to the ER, and on examination, fully conscious but drowsy girl. She suffered headache, right-sided, and 6 nerve boluses and hemiparesis. CT scan and MRI showed this cavernous angioma, and actually this sees that it's like fluid levels. And we operated on her. And then that's after first operation, actually that was a problem with this girl. We could not identify the cavernous angioma inside the hematoma, maybe because we operated so quick. It's the same night when the patient came, and that is, I don't know, but we didn't identify it. So few days later, she had second attack of cavernous bleeding and deteriorated. Then we operated on her again after a week, a few days, and that is removed, and the cavernous angioma identified and removed. That's the residual of blood, and that is her outcome after 1 month, and she is doing extremely well now. She has a residual of weakness, but otherwise the cranial nerve is improved. There is another patient actually also going for the brainstem. He was 28-year-old. He was talking in the phone, and he said all of a sudden he could not hear who was talking to, as a severe attack of headache and lost hearing as he was talking in his phone. And he came, he was fully conscious, oriented, and lower cranial nervous palsy, and he had the same, that is cavernous angioma, and that is operated through lateral pontine approach, and that is post-operative, and he did very well. That is as the incision in the lateral pontine, and that is as we delivering out the cavernous angioma from the brainstem. We have other cases, like 60-year-old lady suffered an attack of headache and followed 3 days later by an epileptic fit. She was seen in service of neurological, in our service, she is neurologically free. CT scan and MRI showed multiple cavernous angioma. One of these cavernous angiomas was in the left parietal lobe with evidence of bleeding. Patient has 2 cavernous angioma in the right temporal lobe. So the patient refused surgery. No, this patient who's actually refused surgery, and that actually treated with anti-epileptic drugs, and she is in full control, and she's doing so far so well. We offered her surgery, but she refused. We have another case that is a 54-year-old lady has complaining of epilepsy since her childhood, and she was diagnosed as a case of depression and personal behavior changes, bipolar actually, and she admitted in the hospital because she had status epilepticus. We find that she has a large cavernous angioma, and that was particular type, that is the whole surface of the cavernous angioma was full of calcifications. And that is the patient is removed, the cavernous angioma removed, and actually the patient condition is not only improved, her psychiatric problem much improved, and she actually, as her children said, that is she became another person. And that is a cavernous angioma when we delivered out, and had that it is in one piece, and you see that it's full of calcification on the surface of it. There are other cases, 15-year-old child, young man, or a case of epilepsy from age of 2-year-old. And this is the point why I would like to make of this. That is actually a patient who have continuous epilepsy, even since childhood, should be really probably investigated with MRI and CT scan. It's not enough to label them with as an epileptic case and continue treating them with epilepsy without reaching diagnosis. So MRI done lately, and then we find that he has a cavernous angioma with large frontal and was removed easy. And actually 3 years later, he is off medication. Another case, this is a full-term baby. Was delivered with APGAR score 8.3 days later. The newborn suddenly became irritable and subsequently lost consciousness. That's why he was admitted in pediatric ICU. Urgent CT scan and MRI showed large right occipital cavernous angioma and bleeding. The patient was taken on the third day of his life to the OR, and the hematoma was removed, and the cavernous angioma was removed. That was a huge cavernous angioma, as you see, and that is post-operative. This child, actually, I'm following because he was the son of our head nurse of pediatric unit. And that is at the age of 2 years. Now he is 21 years, and he is actually graduated from the university and actually without neurological deficit. We have another cases, small cavernous angioma. This is patient, 26-year-old, complaint of epilepsy, controlled with stegratol, and he has a very small cavernous angioma in the right temporal, in the right frontal, which can be easy and safely approved. But he refused the surgery. As long as the epilepsy is controlled, we are following him. We put the surgery, the option of surgery on his card in front of him, but we are following him, and he is so far doing well. In other cases, that 64-year-old lady was diagnosed also of cases of epilepsy over 20 years. And epilepsy is well controlled with medication, and she always refusing to be operated upon. And I am following her for 7 years, and she's doing so far so well. And that is, she has also in the temporal cavernous angioma is rather approachable in the right side, easy, but we offered her surgery, but she's refusing, and she's continuing with cavernous. Now we go to the tricky part and the difficult part, for me at least. We have families, as I said, 3 families which they have multiple people of cavernous angiomas. Okay. So the characters of this kind of family cavernous angiomas, multiplicity of the lesions and various size and locations, and the majority complained by epilepsy, or 2 of them actually were asymptomatic. They are only, we discovered when we screened the whole family. Majority of these cases are supratentorial. And the 3 families, as I said, they are Saudi, and they are from our area, from the Eastern province where I am, and they were all genetically study, and they were found that the 3 genes, CC1, 2, and 3, found on the 7q and 7p and 3p chromosomes, respectively. So I will present a case of them. This is a 28-month-old girl. She's referred to the hospital first time, and as a case of refractory epilepsy. And we did for her the MRI, and we find that she has cavernous angioma. This one, multiple cavernous. We operated on her, and we operated on her, and actually she went very well. And that is a girl in the hospital almost the 3rd day after the surgery. She was well. Few years later, 5 years later, she came again with epilepsy. She had that after the first, we put her on antiepileptic drug for 1 year, and as she had no further attacks, the neurologist decided to stop the antiepileptic drug at the age of 1 year, or the age of 2 years. And then 3 years later, she got another attack of epilepsy, repeated MRI, we find another cavernous angioma, but this time in the frontal. Operated upon. 6 years later, she came back with cranial nervous palsy, and that is this. We did an MRI, we find she has a brainstem cavernous angioma, where she operated for. Now, she had a parietal and occipital lesion, discovered later. So she has, as today, this is her last MRI few months. I operated this lady 5 times. 1 for the temporal, 1 the frontal, 1 for the brainstem, 1 the occipital one, and 1 temporal as well, 5 times. Now she has new cavernous angiomas there and there and there and there. So, as you see, so the question is, what to do next? She is 18-year-old. She is a university student, started university student. Epilepsy is controlled. She managed. But how many times should we operate on her? Is gamma knife is going to help? We actually send her for gamma knife. And that is our last option because they are 7. But if they are in the future, we expect a growing of such a tumor. What shall we do next? This is a question which really we don't know what to do with this. So I hope I'm not over time. I would like to just conclude. Microsurgical resection of cavernous malformation is highly indicated if the patient suffers severe symptoms such as intractable seizure, progressive neurological deterioration, 1 severe hemorrhage in a new non-eloquent region of the brain, or at least 2 severe hemorrhage in eloquent area. Result of microsurgical resection of cavernous CCMS from brainstem is rewarding. There are many reports about that, and the role of radiosurgery in cavernous angioma needs further study. There is no consensus about how effective it is. And symptomatic treated or cavernous angioma, epilepsy or headache can be observed. But that is the option of surgery should be there, but could be safely observed. So if we can just make this summary of a plan, a strategic plan. So cavernous angioma, either it is incidental, discovered, or it is or presented as epilepsy, or presented by hemorrhage. So if it is incidental and no clinical presentation, no headache, no epilepsy, I think she could be continued conservative, and the MRI may be repeated every year. But if it is an epilepsy presented by epilepsy, now we have to do either it's controlled or not controlled, or intractable epilepsy. If it is controlled and no surgical deficit, and that is and you offered surgery, if it's approachable and the patient refuses, still there is a room for conservative treatment. But if that is a patient has neurological deficit with it, It's a neurological deficit due to the location of it. So surgery is options, conservative, radiosurgery is questions. But when there is a hemorrhage, this is another story. So if it is mild hemorrhage, causing epilepsy or headache, or causing neurological deficit. If mild hemorrhage causing epilepsy or headache, this can shift it to the epilepsy as the epileptic group and treated in the same algorithm or the same way. But if the patient has a neurological deficit, I think that is with the hemorrhage, rather than it is large or small, surgery is indicated and should be operated, hematomas removed, and cavernous sinuses removed. It is the same thing if it is the first hemorrhage in non-eloquent or second in eloquent area. So this is just what my thought out of the experience of our humble, our limited experience, personal, and just to put it in this algorithm, which may help in making a plan or making a decision. Thank you very much.
Thank you very much, Professor Ahmed Ammar, for this great talk. Another excellent presentation. Today's all the presentations are very high standard in quality. I think now it's time to introduce our next speaker, Dr. Amir Khorashi. He is a young African neurosurgeon who is practicing in Kenya, in Nairobi. Amir Khorashi was trained under the mentorship of Professor Alan Taylor in University of Cape Town in South Africa. In this occasion, I'd like to thank Professor Alan Taylor for all the efforts he's doing in the process of education and training of African neurosurgery in the specialty of endovascular and cerebrovascular surgery. Thank you, Amir. Please go ahead.
Prof. Nasser, thank you very, very much for this very kind invitation to your 37th webinar. It is a true honor to speak amongst giants, and having Prof. Taylor is really the icing on this cake for me. This is going to be a basic talk. It's not going to be as high-end as some of the wonderful talks that we've just seen. And this is something that I had sort of made to help me understand how the internal carotid, the external carotid, and the cerebrovascular system come about. And I hope to share this with you through an animated talk. Sorry, my slides are not progressing. Let's do that again. Maybe desktop, show desktop. Play, are you seeing that? Okay,
no, it is working again. It's
okay,
good,
thank you. Thank you, Professor.
Okay.
Oh gosh. No, I'm sorry. That's my slides seem to have stopped. Are you able to see this? No.
Amir, no, take your time, don't worry. But it's not, we couldn't see your screen.
Let me try and share again.
We can see your screen now.
Okay. Okay.
Yes,
Thank
that's
you.
good. That's good.
Thank you very much, Professor.
Thank you.
Okay, the story begins. So our early central nervous system really starts off as a very simple tube. This neural tube, and essentially when it's less than 200 micron, relies on simple diffusion to obtain its oxygen and nutrients. But as this tube grows, it now needs to start developing a blood supply, and that blood supply initially starts from its surface, an area called the meninx primitiva, and there are three longitudinal vessels that now will develop just ventral to this tube. We'll start off with a longitudinal neural system, and this is what is going to give rise to the vertebrovascular system. And from the developing truncus arteriosus of the heart, we have the dorsal aorta and the ventral aorta. Now, there are 6 pairs of pharyngeal arches that will now develop between the dorsal and ventral aorta, but for the purposes of now developing the internal carotid and external carotid systems, it's really the upper 3 arches that are very, very important to us. Now, there are very early on, there are primitive vessels that will link the longitudinal neural system to the dorsal aorta. But by the time the embryo is 15 millimeters, these early embryonic vessels will regress, paving way for a very important vessel, the posterior division, which will come off the tip of the dorsal aorta and come to essentially join the longitudinal neural system, and its sister, the anterior division, which goes to now perfuse the developing prosencephalon. From that anterior division, we have a ventral ophthalmic artery, and from the very rostral the dorsal aorta, a dorsal ophthalmic artery, which both go and now perfuse the developing eye and orbit, and essentially below that, a primitive maxillary artery, which goes to now perfuse the Rathge's pouch. Now, the dorsal aorta, the posterior division takes on a new name, and we now start calling it a posterior communicating artery. The anterior division going up to the prosencephalon now becomes the anterior cerebral artery. So now we're seeing where these early vessels are coming from. The dorsal aorta, if one looks at the very bottom of the screen, below the 3rd arch, involutes. This causes blood supply to now come through the ventral aorta, through the 3rd arch, and up into the dorsal aorta. The ventral aorta below the 3rd arch is now turns into the common carotid artery, and that 3rd arch and dorsal aorta now form our primitive internal carotid artery. There's a very important sort of connection that forms between the 2nd and 1st arch, and we'll have a look at this in one of the subsequent slides. Once that forms, there are important regressions that occur, and that proximal aspect where the 1st and 2nd arches come to join the ventral aorta regress with a smaller regression of part of the 1st arch, leaving a small stump that we call the mandibular artery. Now, the 2nd arch and that important connection I spoke about with the 1st arch become the hyostopidial system. And in fact, that link that we can see will form the future stopedial artery, and I'll show you that. Now, there are very important paired ventral pharyngeal arteries that will come off the very proximal aspect of the 3rd arch, and these give rise to now the lingual facial system. Another very important connection comes in between that 3rd arch and now linked to the hyostopidial system. If one looks at the top, the primitive ophthalmic artery seems to now regress, and it migrates more caudally to now form the ophthalmic artery proper. The dorsal ophthalmic artery will give us the infralateral trunk. This is in the adult, and the primitive maxillary becomes the posterior inferior hypophyseal artery. So moving on with these further regressions, and this is just the same picture in a slightly different format, we're able to see the ventral pharyngeal artery giving us the internal maxillary, and from there we have the middle meningeal artery. So if one looks at what's happening in the lower right side of the screen, if I just put a circle around that, this is really the early precursor to the external carotid. So this is where the early external carotid artery comes from. If I move on, just going back, there are those important vessels that I spoke about, and they seem to have regressed, but their importance really comes about when there is a sectional agenesis of that internal carotid artery. We must remember that the internal carotid is not one single pipe that forms, but many little pipes that come to join each other. And indeed, these primitive vessels come in at points that will from one section to the next. So should you get sectional agenesis of a part of that carotid, those primitive vessels do not regress, but they remain to now give supply to the distal internal carotid. This is also a wonderful way because it gives us a way to name parts of the internal carotid or the sections of the internal carotid from 1 to 6. There are various ways that the internal carotid has been named, but this really makes the most sense from an embryological standpoint. So the first section is the ascending cervical carotid, with the second section being that piece of carotid that goes, or it's the ascending carotid through the carotid canal, and it goes through the petrous bone. The third section comes it's the horizontal petrous segment with the fourth section going over foramen lacerum and into the lower end of the cavernous sinus. The fifth section is the horizontal cavernous section, with the sixth being that clinoidal section. So let's look at this. And I mentioned this earlier, this very important vessel called the stapedial artery. I'd like to put in a few foramina here. We'll start with the carotid canal, foramen spinosum, and the superiorbital fissure. Here's a lateral view of that carotid artery as it loops up, and there is our cavernous loop there. Now, proximal in the intracranial internal carotid, we have this important vessel called the hyoid artery, which we had seen arising from that second arch that I showed you. From that, we have a stapedial artery. Now, this very important vessel has got a superior ramus that comes to supply the dura and goes through, sends a branch through the superorbital fissure, an orbital branch to come and supply the structures around the eye. There's an inferior ramus that comes through foramen spinosum, which that vessel is called the maxillomandibular artery, and that comes to anastomose with those ascending branches of the ventral pharyngeal trunk. Now this is important because we know that blood supply through the stapedial comes in a sort of a craniocaudal way. So the early stapedial artery really gives blood supply to the structures of the early developing face, but that's not the case in us. As this vessel regresses, we then have reversal of flow coming through the ventral pharyngeal into the maxillomandibular, coming to supply the dura and to the eye. When that happens, that ventral pharyngeal trunk, which I mentioned gives rise to the internal max, will send blood not through the maxillomandibular, but now that changes name to become the middle meningeal. So this is important because we're able to see that the middle meningeal artery that we know comes to give supply to the dura, but also can be very important because it can give blood supply through to the orbit and to the eye. And I'll show you that in an angiogram in a subsequent slide. Let's have a look at the ophthalmic artery now. So we'll just add the optic canal and we'll put in an eye with a little cornea, a lens, and a little optic nerve. We know the ventral ophthalmic artery, which is a branch that comes off the anterior cerebral artery very early on, comes through the optic canal to go and supply the eye. We have a dorsal ophthalmic artery, which I showed you earlier, which comes through the superorbital fissure, also to come and supply the eye. So there's a very rich anastomosis. And in the early embryo, we have all three vessels, the ventral ophthalmic, the dorsal ophthalmic, and that orbital branch coming from the superior ramus of these stapedial artery, all giving blood supply to the eye. Let's have a look at a few other things. They are the dorsal ophthalmic. So I'll put in a few foramina now, the optic canal, superorbital fissure, the foramen rotundum, and foramen ovale. Here's our carotid artery with that cavernous loop. Now, coming from the very top, I had mentioned earlier, there is a ventral ophthalmic artery that comes from the anterior cerebral, but that's not the pattern that we see when we do angiograms. Indeed, what happens is that vessel will often regress and seemingly seems to almost migrate more caudally to give us the ophthalmic artery proper, which we tend to see. The dorsal aorta, the dorsal ophthalmic, the proximal aspect forms the infralateral trunk, and the ramus, that branch that goes through the superorbital fissure, gives us the deep recurrent ophthalmic branch going to the eye. Now, from that, the infralateral trunk, there's a very rich anastomosis with the external carotid, and we'll have a look at that. So we have the arterial foramen rotundum, which comes to anastomose with branches of the internal max. We then have a branch that goes through foramen ovale with a branch of the trigeminal nerve coming to anastomose with the accessory meningeal, another branch of the internal max. We have a branch that comes posteriorly to come and meet the middle meningeal, which is essentially one of the stapedial collaterals, and a branch that comes to foramen lacerum, which has a very rich anastomosis with branches of the ascending pharyngeal. So here we're able to see how important the infralateral trunk is and all the very rich anastomotic sites it has. And should there be a sectional agenesis of that carotid more proximal to this, the infralateral trunk really serves to help supply blood to the distal internal carotid. And I'd like to share these angiograms with you. These angiograms were done on children at the University of Cape Town. All of these have been provided by Professor Alan Taylor. So this is a lateral carotid injection. And here we're able to see something interesting. So if one looks at here, we're able to see this choroidal blush because the ophthalmic artery comes from the internal carotid, and this crescenteric moon-shaped thing, which a lot of Muslims will be looking out next week, which will mark the month of Ramadan, is really blood supply to the choroid and that retina. But let's have a look at this angiogram in a different child. So this is an internal carotid injection, but we don't see the ophthalmic filling here. And certainly, if we look in this region here, we don't see that choroidal blush. So the question is, how is this eye getting its blood supply? So we've just learned that one of the potential routes is through the middle meningeal. So let's go and do a carotid injection of the external carotid. And here we have it, the middle meningeal, and there we're able to see that deep recurrent ophthalmic branch coming to give blood supply to the eye. So in this child, the retina is being supplied by the external carotid. I'd like to quickly move on to the vertebrovascular system, and hopefully should be done in my 20 minutes. To just start off, this early neural tube, one's able to compare to something like an earthworm. So it has a segmental blood supply. But as it grows, it needs to start having a longitudinal one that essentially can span along the entire length of this neural cord. Now, this is not the pattern that we find in humans. With intersegmental branches that start to form, and I'm sorry you can't see the very bottom because of this little icon on the bottom, but number one there represents a midline longitudinal intersegmental anastomosis. And what we essentially have is we have intersegmental anastomotic channels that start to form. Number two is a paramedial longitudinal and number three is the longitudinal intersegmental anastomosis. So if one was to imagine this neural tube and a vessel that would run through the midline, that essentially, number one, would be the basilar artery and the anterior spinal artery, running right down the midline. If one looks at number two, which is slightly off midline, the paramedial longitudinal intersegmental anastomosis, this is exemplified by the lateral spinal arteries that we see along the spinal cord. And if one looks at number three, the longitudinal intersegmental anastomosis, this is exemplified by the vertebral arteries that we find. So what happens when we start getting into segmental vessels forming between these segmental vessels? Well, we no longer need to have all these segmental vessels, so they start to regress, and they regress in various ways, but most people, and it'll be a common sort of pattern. So here we can see an example of vessels that are regressing with now mergers that start forming between some of those longitudinal anastomoses that I spoke about. So let's have a look at the common pattern of the vertebrovascular junction that we see in textbooks. This is what it looks like. And at those segmental levels that we can see, starting off with the ICA, the pica, and at C1, C2, C3, up what we can see here is the vertebral artery. Okay, we can't see the pointer. Okay. And right in the middle there, we can see the basilar artery on top with the anterior spinal down the midline. But it's also easy to now realize that this pattern may not happen in everyone, and indeed it doesn't. There are intersegmental vessels that will now form. So for example, if that segmental vessel was to completely regress, and now you have an intersegmental level coming to now supply that territory, what essentially would this be? This would be an ICA-PICA, an ICA that has now taken over the territorial blood supply of the conventional PICA. Let's have a look at another example. So here we have regression of that segmental vessel with a vessel coming from C1, giving supply to the PICA territory, and this would be a C1 PICA. Let's have a look at another example. So here we can see almost a duplication or an intersegmental vessel that along that number 2, that paramedian intersegmental anastomosis. And this is essentially a vertebral duplication at C1, C2, with one of the leaves obviously running within the dura. So one has to be careful if this is the case during an operation. What do we see in this example? We have that segmental vessel that regresses, and the PICA supply coming from C2 with a hypoplastic vertebral artery on that side. This is another variant that we sometimes see on angiograms. And coming towards the end, there is a regression there. So what do we have here? So we can see that the vertebral artery on one side is now the supply to the PICA, and there's been an absence of that distal vert on that side. So that's what we're seeing. Okay, so these are very beautiful anatomical dissections that are courtesy of Philip Mercier. And here we're looking at 3 sort of examples. So on our extreme left, we've got a classical PICA, and note how you see important brainstem perforators coming from it. In our ICA-PICA, we don't see the PICA lower down, and indeed in this case, we have brainstem perforators coming from the vertebral artery with a very large ICA that seems almost to loop down to the PICA territory, supplying that area. And in our right picture, a C1 PICA, we don't see those perforators from the PICA coming off the brainstem. They are coming off the vert. And this is important when it comes to patients with brain tumors around the foramen magnum area, or meningiomas around the foramen magnum area. Nearing the end of the talk, my last 2 slides, I'd like to talk about dedicated vessels and various junctional vessels that come between the longitudinal and carotid arteries. What I've drawn here is the secondary brain vesicles, and we'll just name them, starting with the telencephalon, the diencephalon, the mesencephalon, the metencephalon, and lastly, the myelencephalon, which forms our medulla. Now, ventral to these secondary brain vesicles, like we had said, we've got the internal carotid artery and the longitudinal neural system that arise there. And these give blood supply to almost dedicated areas. So like Professor Taylor had showed us, we know that the telencephalic blood supply really comes from the anterior cerebral artery. Now, what happens in smaller animals is that because their hemispheres haven't grown, they really have perforators just coming to supply the basal ganglia. But as the hemispheres grow, these perforators also grow, and one of them takes over a cortical blood supply. And a perforator that starts supplying the cortex, we simply start calling a middle cerebral artery. The diencephalon is supplied by the anterior choroidal. The mesencephalon has 2 sort of vessels coming to it, the posterior choroidal and the collicular arteries that we had seen in Professor Taylor's wonderful talk. The metencephalon has the superior cerebella and the ICA. And lastly, the myelencephalon has the PICA. We had looked at this important connection called the PCOM and some of the other sort of connections that had regressed with time. So the primitive trigeminal, in order to take, if present, will supply the mesencephalon and will link up to the basilar. The high hypoglossal and proatlantal, if present, will grow from the internal carotid through to the vertebral arteries. And that last one, the proatlantal too, if present, will be an anastomotic site between the external and internal carotids. This is just a picture of that showing a persistent trigeminal artery pointed out by that arrows. So we've got a vessel from the internal carotid going to the basilar artery and now taking over the posterior cerebral supply. I think I've reached my 20 minutes, and with that, thank you very, very much. And once again, thank you very much for this very kind invitation to this wonderful webinar.
Thanks, Amir, for this great talk with this beautiful animation. Actually, the neuroanatomy is one of the most difficult specialties, especially the cerebrovascular anatomy, and you succeeded to make your presentation as simple as possible. One of our guests during our series of webinars was a young neurosurgeon from Asia. Her name is Abida Shah. She's working with Atul Goel. She is presenting also very good neuroanatomy in a very simple way. And so now we have two very good lecturers, one from Africa, Amir Khorashi, and one from Asia, Abida Shah, who can present neuroanatomy in such simple way. Thank you very much. Now I ask Professor Hisham Bassiouni to introduce our last speaker, and then we open discussion.
Yes, thank you very much. And I would propose, if you have not send it to YouTube, you should send it to YouTube as a presentation, a short presentation. You will get a lot of likes from this. So the next speaker is Professor, I hope I pronounced it correctly, please, or correct me if I'm wrong, by Tube, is it right? From
yes,
Senegal,
right.
who's talking about the surgical treatment of paraclinoid aneurysms. It's your screen.
Do you see my screen now?
Yes, perfect.
Okay.
Yes, perfect.
I want to start with thanking a lot my dear friend Nasser El-Ghandour for the invitation to this great webinar. It's a real pleasure for me to share this panel with great personality of neurosurgery as Professor Alan Taylor, Professor Morcos, and I really love the presentation from Professor Amir Qureshi. That was really very, very interesting. Thank you for, I've learned a lot. I will talk about the surgical treatment of paraclinoid aneurysm, our experience here in Dakar. And now, for those who don't know Senegal, Senegal is a little country of West Africa with 16 million people. And our main neurosurgical unit is in Fan Hospital in Dakar. And in this unit, we have a great team with Professor Bajan, who has retired since a few months now. And the guy with whom I am working every day, really great team. The paraclinoid aneurysm are really rare aneurysm because they represent between 4 and 6% of all intracranial aneurysm. And they have been known by their low risk of bleeding. But they have special kind of mass effect when they are giant, and they can affect the optic nerve with compression. Relative to the complex anatomy, they are complex aneurysm to treat, and we have to understand the anatomy of the anterior clinoid process and the distal drawing for a good clip application to the aneurysms. We know today that endovascular option can take care about those aneurysms for a great part of them, especially flow diverters, but The risk of visual impairment post-procedure is not really well known, actually. I think there are many studies searching to know what is the real risk for visual function after flow diverters. And surgery is really complex because bony anatomy we need to understand, and we have to deal with the risk on visual function. In our countries, like Senegal, we do not have any endovascular option, so we just have surgery. So we have to know how to treat those kind of aneurysm. Those aneurysms are arising from C5 and C6 segment of the ICA, like on this picture. And they are classified, many authors have tried to classify them. And we use especially the Barami classification, classifies those aneurysms in 4 or 5 types, and especially the ophthalmic, the superior hypophyseal aneurysm, and ZOR on the ventral C5 segments. My screen not moving, no way. Have problem with my, okay. On those classification, we have 2 types of ophthalmic aneurysm. Type 1A is a true ophthalmic aneurysm, and type 1B is a ophthalmic aneurysm not arising from the immersion of the ophthalmic artery. And we have other type, the more frequent, the type 2 in the ventral aspect on the ICA, on the type, the medial aspect on the ICA, and the type 4 is a rare type of aneurysms. We understand the cervical anatomy, especially the bony anatomy of the region. The clinoid process here is attached to the rest of the skull base by three roots. The first root, which is the easiest to block, is along the optic canal to the planum sphenoidal, and there is a lateral root on the wing of the sphenoid, and the last root is on the optic strut. It's important to understand that the optic strut, the length of the optic strut is the difficulty of the anterior clinoidectomy is depending on the length of the optic strut. If you have a thin optic strut, it's really very easy. But if the optic strut is very thick, it may be very difficult, especially if you use microrongers to do the clinoidectomy. Here we see the same thing. Here is the anterior clinic process, and here we are seeing the dural rings, the distal and the proximal dural. You see here how those rings are attaching the ICA to the bone, and it's easy to understand that if you don't detach those rings from the ICA, it will be difficult to mobilize the ICA and to applicate your clip in the best fashion. And after removal of the bone, you see the meningeal and nerve relationship with the ICA. Here, all the branch of the trigeminal nerve, and here after the removal of the ICP, you see here the distal dural ring, and this relationship with the ophthalmic artery. And you see you have to go here in the axilla of the ophthalmic artery to cut and to dissect completely this distal dural ring, and that will allow you to mobilize posteriorly the ICA and here these pictures show us the relationship of this region with some special arteries, the superior hypophyseal artery. You can be involved when you have aneurysm developing on the medial aspect of the ICA. And you have to pay attention to this artery and not to catch him in your clip blades. You have to dissect it if it is present, and you have to spare it to the clip blades. And not to forget the pecum and the intercorridal. Sometimes they are not so they are really close, especially when the neck is huge, the aneurysm neck is huge, and when you apply right angle fenestrated clip, you have to look if you have not cut any of those branches. The case surgical steps for this surgery, there are three important surgical steps. First of all, the anterior clinectomy. You can do it extradurally or intradurally. Here in Dakar, we use the extradural fashion, and we do it with micro rongeurs. It's possible because we do not have all the time our drills. We do not have drill, and we are obliged to use micro ronger. And it's possible. It took more time. It's time consuming. You have to pay attention to not to injure the optic nerve, but it's possible. You can use the micro rongeurs on your Kerrison, and you can remove a great part of this anterior clinoid process. Here we are dissecting with a micro dissector here, a rotan dissector, to separate the bone from the dura. Here the sphenoid, the tip of the clinoid is going. And after, you can use micro Kirson to complete the removal of this bony structure. At the end, you see here we are opening the optic canal to facilitate the mobilization of the optic nerve. And here you see here, after peeling the dura propria of the temporal of the cavernous sinus, you see here the V1, V2, and V3 going into the cavernous sinus. And after, you have to dissect the distal dural ring. It's really a key point, because if you do not do this dissection, you will not mobilize properly the ICA, and you will not apply your clipper properly. So it's really a very important surgical step, the dissection of the distal dural ring, and the dissection of this distal dural ring, and it, as I was saying, it will allow you to mobilize the ICA and to clip properly. What about the proximal control? For our first cases, we usually expose the ICA in the neck, but for since 2-3 years, we do not. We just try to access to the C5 segment of the ICA to put our temporary clip for proximal control. I think it's possible. If you dissect properly the distal dural ring, you can access to the C5 segment of the ICA and to put a temporary clip for proximal control. In the cavernous size, it's also possible. What we do not do that procedure, you can apply a temporary clip into the Parkinson triangle in the cavernous sinus. Here, this picture demonstrates how we do our distal dural dissection here, a left side parenteral approach, cutting the arachnoid and going deep in the sylvian fissure. Here you have here the ICA. And we'll continue our dissection, and we'll begin to open the falciform ligament. Here we are opening dissecting the distal dural ring over the opening the falciform ligament. You have to try to dissect circumferentially around the ICA to be able to mobilize the ICA for proper clipping. Here you are seeing the ophthalmic artery going into the optic canal after opening the distal the middle part of the distal dural ring. Here is and here we're going laterally to continue our dissection to free completely the ICA from those dural attached. In Dakar, since 2013, we have operating about 346 aneurysm, and 33 of them was paraclinical cases. They are there was 25 women for 8 men, and 29 cases was ruptured. We found 5 cases of pre-op visual deficit, and the ophthalmic type was the most common type of aneurysm. Our first illustrative case is that 46-year-old woman received with a subarachnoid hemorrhage case with a WFNS3, and the angio-CT shows this aneurysm is type 2, a superior hypophyseal aneurysm, artery aneurysm, but it's curiously developed laterally of the ICA. We see the aneurysm is lateral to the ICA, and the ICA is just here, and you will see it in the video. Here we try to open the distal dural ring, opening the falciform ligament. Opening the distal dural ring. Here we are limited by the optic struct because we don't have a drill to minimize the bony structure here. We are a little bit limited by the optic struct here. Here we are dissecting the aneurysm after now we were too aggressive on the dissection, and we had a rupture, intraoperative rupture of the aneurysm, but we had a proximal control on the neck, and that was not really a very big deal, and we succeed to control the bleeding and to apply properly a clip. The first straight clip was not the good one, and we used after angle clip. It stopped the bleeding, and the aneurysm was secured. Here you see the interluminal aneurysm here, and the ICA is here. Now it's free, and the optic nerve also, and the post-operative control without any deficit, any additional deficit. The second case is really very, very interesting case. It's the case of the 53-year-old woman, non-ruptured case, type 2 subarachnoid hemorrhage, superior hypophyseal aneurysm. And if you look at the angiogram, you see that aneurysm is developed on the ventral aspect of the ICA and majorly. But when we expose after a pterygium approach, you find this kind of lesion continuing the dura. That was a meningioma, a clinoidal meningioma, just sitting on the optic nerve on the ICA. So we didn't understand the first moment because we didn't see the meningioma on the preoperative images, but we had to dissect and to remove the meningioma before clipping the aneurysm. And here we are peeling the meningioma from the ICA with a micro scissor. Progressively, we have dissected the meningioma from the ICA. And after the removal of the meningioma, we turn our attention to the aneurysm, and we continue our dural distal ring dissection. And here the aneurysm is coming into view here. You see the dilatation of the ICA here, showing the beginning of the aneurysm. We continue our dissection, separating the aneurysm from the ventral aspect of the optic nerve and the chiasm. And after proximal control on the C5 segment, we apply a right-angled fenestrated clip to secure the aneurysm. But after the clipping, we just found that our clip was really too close from the PCAM. And you will see the PCAM, I think the PCAM was compromised by the clipping, and we decided the PCAM is here. And I think the PCAM was compromised by the clip. So we decide to remove this clip and to apply another clip proximally to the PCAM. And I think it was done with this new clip. And the post-operative CT was uneventful, and the patient has a very good recovery. This case is also very interesting. It's a case of a young of 25, a 45-year-old with a giant aneurysm. This patient present to our clinic with a sign of stroke, ischemic stroke, and the CT shows this giant thrombosed aneurysm. And here you see just the proximal part of the aneurysm which was circulating. We decide to decompress the optic nerve and to clip the aneurysm. Here's the dissection. We are exposing this giant aneurysm. Dissecting under the frontal lobe to expose the optic nerve here. Optic nerve and chiasm are exposed. And here you see the PCAM coming into view, and the anterior corridor is not very close here. And we were obliged, the aneurysm was very thick. We was obliged to open the aneurysm and to remove the thrombus before continuing our clipping. That was what we have done here. And after removing an important part of the thrombus, we were okay to dissect more aggressively the aneurysm and to put a clip on the neck. Here, our first clip going in the neck, we pay attention on the optic nerve, not to touch the optic nerve, and we put a second clip to secure our clipping procedure. And the post-operative control seeing no additional problem. What about the contralateral approach? That's the last case. Sometimes you can approach those aneurysms from the contralateral side. Here, this woman was admitted to our clinic with a sovereign hemorrhage coming probably from the ACOM, but the angio, CT angio shows 3 aneurysms. So left PCAM and another right superior hypophyseal aneurysm. So we decided to approach this patient from the left side, terminal approach, and we were able to clip all the 3 aneurysms, opening the Sylvian fissure here and putting the first clip on the PCAM, the left PCAM. After we turn our attention to the superior hypophyseal aneurysm that we were able to clip in the anterooptic space here. It was possible to put a clip. Here we are optic nerve, left optic nerve, right optic nerve, and here you see the ICA and the aneurysm, which is projecting medially to from the ICA. So we were able to put a clip on this aneurysm using the contralateral side. Okay. So what was the outcome? The outcome was good for 24 cases. And for 5 cases, they were not really very good. And we have 4 days, four cases of death. And on 1 case was especially due to our lack of experience. I have to apologize it because I didn't understand really the anatomy before I put the clip, and I make a tear in the neck of the aneurysm, and the post-operative course was very bad for this patient. She died. And for the optic function, we have 2 patients with worsening of their visual status, but 1 case had recovered after a few months, and we have 1 permanent third nerve palsy. And after control, we have 2 cases of incomplete clipping. I will conclude by saying that there were difficult cases for surgery, but they were doable even if in our condition. And in Africa or other LMIC country, the surgery is just the only option is available, because flow diverters or coil are very expensive for our patient, and we do not have any kind of solution for those kind of the treatment. So we have to learn how to treat those kind of aneurysm especially by using labs, going to labs and learning our anatomy, going dissection. I would really finish by saying thank you to our mentor, Professor Cerebrovascular, who was our chairman from my beginning of my internship, my residentship, from December 2020. And that was a guy who made a lot for Senegalese neurosurgery and African neurosurgery. And we'll never say enough thank you for all he has done for us and for the Senegalese neurosurgery. Thank you, Professor. And thank you. It was my last word.
Thank you, Thayob, for this very good presentation. And I'm glad that in Dakar, in Senegal, you are doing these complicated operations, especially paraclinoid aneurysms, which you operated on 33 patients and among a series of 346 surgical clipping. Thank you very much for presenting the experience of Senegal in dealing with these difficult surgeries. Now I go to Professor Hisham Bassiouni to moderate the discussion.
Yes, thank you very much. Very, very interesting presentations, and I came to the conclusion that the African or Senegalian neurosurgeons are better neurosurgeons than in the Western world, because we have the luxury of having a high-speed drill to do this job and not the Ronja. And it's, well, I think it's very difficult and complicated to do it with the Ronja, but it's very sophisticated. Just one suggestion. You said that you are preferring the extradural clinodectomy, anterior clinodectomy. I think in this case, and we're talking about aneurysms, I think it's more secure if you still revive the technique of the internal carotid in the neck, because I think it's more secure if you've got a premature rupture. So this may endanger, and you are still not having the aneurysms. And I think, of course, intradural clinodectomy would be an alternative, but I think in these cases, I don't know, but you know better. I think in this case, the high-speed drill will be more secure, I think. What do you think about it?
Clearly, I think if I had a high-speed drill, I will use it. But actually, we do not have high-speed drill.
I know, but securing the carotid, the former technique, because you left this technique for securing the carotid in the neck. I think it's a good idea to have this.
Yeah, I think I was telling that for our first case, we was systematically exposed the carotid on the neck. But after some case, we didn't use it. So we just prepared the neck, but we in just 2 or 3 cases we were obliged to expose the ICA. So since we could open the dural ring and expose the C5 segment, but we really don't found if necessary to expose all the time the IC on the neck. But if there is a very big aneurysm, I think it's more safe to do it in the neck than to try to find the C5 segment.
Yes, exactly. Yeah, I think so. There's one question you already answered. It is from our colleague Dr. Gupta in India. Do aneurysms inside the carotid collar also produce subarachnoid hemorrhage? Or you already answered it in your presentation. So maybe you can comment on this.
Yes, I think sometimes it's not very easy because we just have NGO-CT. Sometimes not really very easy to difference that to make the difference if the aneurysm is intra or extradural. But the type 4 of Barami is special because a part of the aneurysm can be intradural and the other part extradural. So when this aneurysm ruptures, in mostly all the time there is subarachnoid hemorrhage. But I don't have a lot of experience for extradural location, but all the cases we have, the hemorrhage was intradural and we had to secure those aneurysms.
Yeah, actually, when the dome of the aneurysms reaches the subarachnoid space, so there will be a subarachnoid hemorrhage. Yeah. So it can we can answer this question with yes, clearly. So the other presentations, I also already proposed to put the embryonic our embryonic history to YouTube. I think it will be great.
Thank you.
So everybody can see it. And the other presentation about cavernous angiomas, about a very interesting Professor Ahmed, the familial cases, and you asked about this this young lady. I think she's now 18 years old, as I remember, about the multiple new development of cavernomas, and I think you asked what shall we do about her. Of course, this is a very difficult task, but I think you already answered this in your flow chart, because as I understood, she's now asymptomatic. And I would compare it with neurofibromatosis. You have development of new neurofibromas, and you only treat the ones who are symptomatic or who have a clearly bleeding or clear bleeding on the MRI. So this would be my proposal. So I think in her case, at the moment at least, you should control. Or do you see it in a different way?
Yeah, thank you, Dr. Hisham. I actually agree. This is a big problem. She's 19-year-old now. She's controlled. She's going to the university. But what's next? And the interesting thing, none of her cavernoma actually obviously bled. However, every time we go, we find this yellowish or hemosiderine staining of the gliosis around it in one way or another. But the problem is she's 19-year-old. Now as we counted, she has around 11 cavernomas in different parts of the brain. Then what's next? What's the future of this girl? We don't know till now. Is really, we give her, send her for gamma knife. She hasn't received it yet, but we will see if even if she will be radiated, stop the growth of these 11 cases. But what about others? Actually, we had a case I didn't include in this because that was not my case. It was another one from another family. It's not a Saudi family. It was an Indian actually. And she has 22 cavernous angiomas, and she was young. And actually, she came with bleeding from different, and actually she died after complications. But it is a problem, and really we don't know what could be happen for her for the future. But at least from ethical point of view, that is, we have to encourage her to live her life as much as possible. But the family, the father and mother, they are aware about what's going on. Actually, her mother, she has a cavernous angioma, and I operated her mother. And her mother is doing well, and she had no recurrence after this first surgery. So the family are very much supporting her. And her colleagues supporting her. That's all what she needs, a great support till we find what we can do with her.
Yeah, thank you very much. Yeah, it's difficult, but well, actually, we are just human beings trying to do our best to help. But of course, there are some cases where you are running behind the disease and hoping that you hold line with the disease. But of course, in these cases, sudden bleedings can disrupt the treatment line, of course.
I can see that somebody raising a hand. Mariam Ghanem, she is Egyptian neurosurgeon. Mariam, are you here? I unmuted your mic. Can you speak? Introduce yourself, please.
Thanks a lot for all my speakers for the presentations. I'm Mariam Ghanem from Al-Ghandour University in Egypt.
Mariam, can you raise your voice, please, and get closer to the mic?
Yes, Dr. Nasser, can you hear me?
Yes, yes.
Better now.
Mariam Ghanem, a neurosurgery specialist from Al-Ghandour University for girls. In fact, this is a great presentation that thank you today. In our people have no experience in neurosurgery or endovascular surgery for girls, not for boys. And usually we refer all these cases for Al-Ghandour University for boys. So this is a great opportunity to listen to this presentation today. Thanks a lot.
Thank you, Mariam. She is just saying a comment that in other university, I think they still need more experience because they are not doing these operations about surgical clipping. Actually, there is conflict between two methods of treatment, the endovascular and the surgical clipping. And I think we need certain guidelines to teach young neurosurgeons when to use clipping and when to use endovascular surgery, because such two modes of treatment were going hand to hand. I remember that Professor Robert Spitzler was our guest in 2 webinars before, and we were discussing the conflict between such two modalities of treatment. Hisham, do you have any other comments?
No, just in my institution, we are doing it together. We are counseling the patient together, and we come to a final recommendation for the patient. Of course, in some cases it can be clipped. In the same case, it can be done by interventional neuroradiologist with the same quality. My personal view in this case is what would I do with my own relatives? And of course, as a neurosurgeon, I like neurosurgery, of course, as we all do. But in these cases, if it can be done in a less invasive way, I think this we would choose for our relatives and for ourselves. So if I've got a very good neuroradiologist, interventionalist, and if he says I can do it, and I can do it complete, that's very important, because partial treatment is no treatment actually. Then I let him do the case, although I could also operate on the patient. So I think this is the way we are cooperating, at least in my institutions.
Thank you very much, Professor Hisham. I think by your words, it's time to close the webinar. It was one of the most successful webinars. At the end of this webinar, I would like to thank all our distinguished speakers, Professor El-Ghandour from South Africa, Professor Jack Morcos from United States of America, Professor Ahmad Hijazi from Egypt, Professor Ahmad Ammar from the Saudi Arabia, Professor Amir Khorashi from Kenya, Professor Maybay Thayoub from Senegal. I also would like to thank Professor Mahmoud Khorashi for contributing to this activity. I would like to thank my friend, Professor Hisham Basyouni, for moderating this session. And I would like to remind everybody that next Friday, we don't have webinar. It is canceled because of the vacation in the Middle East. They have a feast, we have a feast in the Middle East. And so we canceled our operation for our webinar for next Friday. Best wishes to everybody. And we are going to restore our activities again Friday, 21st May on the usual time, 2 p.m. Egypt time, 12 p.m. Greenwich time. I would like also to thank all my organizing committee who are doing such professional job. Mr. Ahmed Magdi, the IT, Dr. Hassan Ala, Dr. Mustafa Abu Leil, Muhammad Arnaout. I would like to thank also Adel Idris for broadcasting over the YouTube and the Facebook page. Thanks to all of you, and so hope to see you all again in another occasion very soon. Thank you.
Thank you very much. Thank you. Have a nice day.
Thank you very much.